Good morning, everyone, and thank you for joining us at the Iowa ACC Fellow Education and Board Prep Lecture Series. Um, can someone confirm to me that you can hear me?
I can hear you.
Yeah, we can hear you. We can hear you, Rashna.
All right, perfect. Thank you. Um, so this is our week 2 of the sessions, and today our topic is going to be electrophysiology again. And thank you all for joining us. Along with me, the planning committee, Shubhadeep Roy, our FIT chair, and Nancy Adams, our chapter executive, extend a warm welcome to you all. As a reminder, please keep your microphones muted. Please be active in the chat. If we are not able to respond to your questions during the question and answer session, we will send it over to you, or we will attach a PDF on the website, create a link there. And again, if you have any questions after, or any suggestions or whatever, feel free to communicate with us. Our topic today is electrophysiology again, followed by 2 weeks of cardiomyopathies coming up, and then we'll have a week of adult congenital. Our speaker, I'm going to start with our first speaker, is going to be Dr. Olshansky, who gave the talk about SVT last week, the excellent lecture. He's going to be our first speaker, talking about syncope. Again, Dr. Olshansky is an emeritus professor of medicine at the University of Iowa Carver College of Medicine, and he's internationally known electrophysiologist. At the University of Iowa, he directed the cardiac electrophysiology and fellowship training program for 6 years. He is recognized globally for his expertise in the evaluation of syncope, assessment of arrhythmia mechanisms, autonomic control of arrhythmias, multi-center randomized clinical arrhythmia trials, and the treatment of atrial and ventricular arrhythmias using device, ablation, and drugs. He is also known for his diversity of interests ranging from technological and mechanistic aspects of cardiac EP to holistic issues regarding medical care and doctor-patient relationships. His research interests are extensive, and he's been involved in numerous clinical trials and has published extensively with over 300 peer-reviewed manuscripts, 4 books, and numerous chapters in key textbooks. He's a member of 8 editorial boards, including JACC, Heart Rhythm, American Heart Journal, Circulation, Arrhythmias, and EP. He has lectured internationally and has been a visiting professor at institutions throughout the world. I will go ahead and let Dr. Olshansky take over at this time.
Well, good morning. Thank you, Mahi and Shubha, and everybody for coming this morning. And I'm very happy to kick things off with syncope. So let me see if I can get this. Okay, hopefully you can see this. Here are my disclosures. And today I'm going to focus on some of the new guidelines on syncope that you probably should review. They're actually fairly extensive. This is one that I was involved with a couple of years ago, a guideline for management of syncope. There was another one about a year later in the European Society of Cardiology guidelines, 2018, which was in many ways very similar, different group of individuals that wrote this, but basically came to the very same conclusions. Here and there, a little bit of differences. And there's also another consensus statement that may be worth looking at, which deals with some autonomic issues such as postural tachycardia syndrome, inappropriate sinus tachycardia, but also vasovagal syncope. So these would be 3 documents that I'm going to refer to through this talk, but also worth looking at some point in time. So syncope, also known as fainting, is a transient loss of consciousness with a rapid, usually complete recovery. There may or may not be some warning or a prodrome. And the thing about this is it's a rather nonspecific, some people would call it a symptom. It's alarming and can be debilitating, but it's very common. And there can be self-limited causes that are benign, or the problem could be a premonitory condition leading to sudden cardiac arrest. So there are various causes for this problem, and it can be divided really into 3 different groups. the reflex types, the neurally mediated types, and then there are the orthostatic types. So each one of these are very common causes for syncope. And orthostatic, of course, could be related to dehydration, or it could be an autonomic problem such as neurogenic orthostatic hypotension in Parkinson's disease. In terms of the reflex types, it can be something that is not related to any other condition in a younger person. It could be a vasodepressor or a cardioinhibitory type response, a vasovagal type response, or it could be triggered by a specific event, such as deglutition, so swallowing, or something in an older person. There may be a specific trigger, and even carotid hypersensitivity would fit into this category. And then there is a category of cardiac, and cardiac really represents a couple of different types. One is an arrhythmia. It could be a bradyarrhythmia or a tachyarrhythmia, or it could be a specific cardiac issue related to a drop in cardiac output for a sudden period of time. And so there could be other structural that leads to an arrhythmia, and this can be a significant problem leading to sudden cardiac death or mortality. So this is an important group to distinguish from the more benign forms, such as reflex-mediated syncope. And orthostatic hypotension may or may not be benign, depending on what is the trigger for this problem. So I want to start with a case, and we'll talk a little about this case throughout this talk. But this is a 52-year-old man who was found down in the street, and he wakes up wondering what happened. He's admitted to the hospital, and there are several questions you might have. One is, well, what happened to him? Did he actually pass out? The next one is this going to happen again? And you have to wonder, is there anything, if it was going to happen again, how are you going to prevent it? Another question, and this is really important, especially for the emergency room physicians, is, and of course for us too, because we get consulted on it all the time in the emergency room, and that is this life-threatening and serious, or can he go home from the emergency room? And so then the issue is what to do about this. Do you admit the patient? What evaluation do you do? What do you do now? What do you have to think about in the long term? So lots of questions about this case, and this is not uncommon in terms of the kinds of presentations you might see in someone with syncope. So the first challenge is to understand the event. Was it really a transient loss of consciousness? And if it was it syncope or was it something else? So part of the guidelines recommends that, first of all, when you have transient loss of consciousness, consider, is it syncope? Is it a seizure disorder? Was it coma? Was it due to a drug overdose? Did someone get hit on the head? So these are the different kinds of things. And if it's syncope, if you suspect it's syncope, then there's a specific pathway to follow, which basically is fairly common sense, but the most critical part of the entire evaluation is to get a good history, consider on physical examination issues such as orthostatic vital signs and also murmurs, etc., any arrhythmia that you might hear, and an EKG. Very simple, but very important. And then with this, you can try to figure out what might be the cause for syncope. And then if you can figure it out, then consider the treatments. On the other hand, there's another thing to consider, and that is, well, if the patient has an ejection fraction at 10% and got a left bundle branch block, is this person also at risk for sudden cardiac death? And that risk may not be necessarily the cause for the syncope. So you have to consider risk assessment along with trying to find the mechanism of what actually happened to the patient. So the evaluation is actually really two parts. One is to try to come to the etiology of what caused syncope, and the other is to look at risk assessment. But of course, in both cases, sometimes it is not so clear, and frequently patients that have this problem are not easily diagnosed with the cause and the risks. So typical presentations to consider for neurocardiogenic is there a trigger? Did someone give blood, for example? Recently, COVID virus has been associated with syncopal episodes. So again, once you see this and you think you might have a neurocardiogenic cause, someone could come in diaphoretic and pale and actually not have a vasovagal episode, but actually have something much more serious going on. So think about the prodrome that's actually happening. That's common with neurocardiogenic responses. In terms of seizure, consider there may have been an aura, there might have been tonic-clonic activity, but consider also that that kind of activity can even occur with asystole or with VT. So this is not necessarily specific for seizure, but also consider that in a seizure, there's a slow recovery. With neurocardiogenic responses, what normally happens is a fatigue sensation after the episode. Orthostatic, so if there are positional changes in symptoms that cause this, and if it's reproducible, then that may be the cause. Cardiac, frequently no prodrome with an abrupt onset. And then there are other conditions to think about, such as psychogenic pseudosyncope, which is an interesting issue because this is something that someone may not necessarily be aware of, that they're actually doing this, purposely. They're not faking it. It's somehow of a conversion reaction or something of the sort that leads to loss of consciousness. So there are various things to consider in terms of the initial evaluation. When it comes to the reflex, there's also a couple of things to consider. First of all, this vasovagal or neurocardiogenic reflex involves an afferent limb, and then also the medulla, so the nucleus tractus solitarius, but also the cerebral cortex, because someone could have fear and that could trigger it, or pain or could trigger it. And so there are many things that are going on, and that leads to an efferent parasympathetic activation and sympathoinhibition, leading to bradycardia and hypotension, usually in combination, but not necessarily. Another thing to consider is even an epileptic episode, such as the temporal lobe epilepsy, can actually trigger a vasovagal reaction. But also consider that this is not necessarily benign, because there are other things that cause syncope that are actually potentially life-threatening that do it by the vasovagal reflex. Pulmonary emboli tend to cause bradycardia and hypotension because of excess pressure on the right ventricle. Essentially, the contractility of the right ventricle goes up. That leads to a so-called Bezold-Jarisch reflex, which also tends to occur in aortic stenosis and inferior infarctions. So these are not necessarily benign, but they are part of this neurocardiogenic reflex. Also consider that there are various associations, such as fatigue with people that have this reflex, or depression. And this can manifest as either bradycardia, asystole, cerebral vasoconstriction, and also vasodepressor responses with bradycardia and hypotension that occur together. The next is to try to determine the cause, make a diagnosis, but of course to make the right diagnosis. Again, most of these diagnoses are inferred and they're presumptive. They're not necessarily based on something that you find on a specific test. So again, going back to the fact that the history is critical, but it's not just getting the history, but it's trying to figure out how the issues that are occurring around whatever event happened could have led to the syncopal spell itself. Orthostatic vital signs are certainly worthwhile, but frequently they're not done. And if they're done far away from the time of the episode, they may be normal, and yet they could still be the cause for the problem, where a drop in blood pressure occurs with standing. Carotid massage, perhaps depending on the history, in older people it may be useful. But again, if you rub on a carotid on an 88 or an 85-year-old, you may get a bradycardic response, but that doesn't mean it caused the episode itself, that is, of syncope. Then there are diagnostic tests to consider, but these need to be used very selectively. Throwing a bunch of tests at somebody is not necessarily going to give you a diagnosis as to what went on. So you might see, and this is not necessarily unusual, where patients get admitted to the hospital and they're in the hospital for a couple of days and a bunch of tests are done. They could be CT scans of the head or the chest. There could be carotid Dopplers. I've even seen that in 20-year-olds, EEGs, a variety of blood tests, and they don't necessarily help in making the diagnosis. And in the guidelines, these are not necessarily recommended. The way to approach the diagnostic interventions is to look at the history and then guide those testing based on the history. So this is basically the recommendation: to get a good history and physical. If the initial evaluation is clear, nothing else needs to be done. If the initial evaluation is unclear, think about specific blood testing. We'll talk a little about that. This could be, in fact, even BNP and troponins, depending on the suspicion and depending on the patient's clinical situation. If there's a suggestion for orthostatic hypotension, then to approach things that way with autonomic evaluation, or even tilt table testing, which we'll talk a little about. And then if there's a concern about cardiovascular abnormalities, consider which test is most appropriate. Monitoring has taken a big role in the management and in the evaluation of syncope. And this could be an implantable loop recorder, or it could be an ambulatory recorder, depending on the clinical situation. In terms of stress testing, echocardiography, EP testing, all these things are worth considering depending on the patient. For some patients, I think it's very reasonable to do an echo on many patients. However, in a young, healthy person who has a normal physical examination, the likelihood of finding something is going to be very small. And then what you find isn't necessarily the cause for syncope in an older person, but it may give you some clues about risk stratification of that particular individual. Another thing that's been useful, and I've seen this been very helpful in some situations, is with phones to record an episode where, if that's possible, and home recordings of episodes can be brought in and evaluated and have been helpful in making a diagnosis of seizure versus syncope. So it's something to consider in someone who has recurrent episodes. Now, I want to present a case to you. This is a 72-year-old man who I took care of when I was in Chicago many years ago. And he had a very large, very complete workup. And let me just explain. He first passed out when he ate a big meal and stood up and then collapsed. He had a new car. He just went to stop at a 7-Eleven to get something to drink. And then he passed out and he drove into a telephone pole, lost his license, and stopped driving, and also almost killed himself. He had a bunch of tests, carotid Dopplers, Holter monitor, MRI scan, EEGs, tilt table test, treadmill, coronary angiogram. Everything was negative. And supposedly, and I've written a book on syncope, or a couple actually, but they thought, okay, so I know something special. I have this special test that I can do that could figure out what actually happened to him. But all I did was I asked him a question. I said, so you said when you drank something, you felt a little bit confused. Does that happen to you a lot? And he says, yeah, when I drink Pepsi or something like that, I feel dizzy and lightheaded and feel like I'm going to pass out. So actually I bought him a Pepsi, and I did the Pepsi challenge, and he actually passed out. He became bradycardic and hypotensive. So he had deglutition syncope. That cost him about 75 cents to make the diagnosis. And, basically the history gave it. And he said, how did you know that was going to happen to me? And I said, well, you told me that. And he said, well, I told all the other doctors, so why couldn't they figure it out? So it's not just getting the history, it's trying to put the pieces together about how the history could have led to the episode that he had. The first time he had this, he had a big meal, he stood up from the table and he collapsed. So avoiding specific triggers may prevent him from having recurrent episodes. Monitoring is helpful though. Monitoring has been helpful and recommended by both the ESC and the American Heart Association, American College of Cardiology, and loop recorders are being used more and more to try to make the diagnosis. But I'll tell you, this is not foolproof. It is useful, but it is not foolproof. We'll talk a little about that. First, let me give you this is an 84-year-old woman who had orthostatic hypotension. She passed out multiple times. She came to the clinic, I stood her up, and she dropped her blood pressure from somewhere about 140 down to about 80, and she got dizzy. So I thought, okay, so that's what's going on with her. But she said, this is not what really is what it's like when I pass out. And she had syncope while she was sitting, and she said she felt like she was going to die. She also had a left bundle branch block. And so here it is. You can see her EKG, and this is not a normal EKG. So you got a left bundle branch block here, and she's a little bradycardic, by the way. So I thought, okay, so she might have had orthostatic hypotension, but she might have something else. So I put a loop recorder in her, and this is what she did. She had asystole for a very long period of time. And that was during an episode, of course, of syncope. So she got a pacemaker and never passed out again. That was many years ago. So again, left bundle branch block is a high risk for potential heart block. And just because you have a finding doesn't mean that finding is the cause for the episode. But there's another problem with monitors. And here it is. Here you see a monitor, patient became asystolic. And you can see on the bottom where the patient hit the ground right over here. But that doesn't tell you the mechanism of the arrhythmia. And why is that important? Well, suppose the episode was vasovagal. I can remember when I was a fellow many years ago, one of my mentors took me around and we saw a 17-year-old man who had WPW syndrome. And he was on a monitor in the hospital, and I was there at the bedside, and my mentor said to the patient, well, we're going to stick a bunch of needles in your legs and put some tubes in there, and we're going to go inside the heart, and we're going to go look for this pathway. The guy got pale, diaphoretic, and passed out and had a 17-second pause. So did that cause, so this that kind of situation, that patient wouldn't necessarily need a pacemaker. Of course, if this is an 85-year-old who keeps passing out and has that, that's a whole different story. So you need to know something about the asystole or the bradycardia and how that relates to the underlying medical conditions. Now, tilt table tests have been useful, but there are also problems with false positives and false negatives. What you see here is what happens with the heart rate and blood pressure on a tilt where someone passes out. And you can see that the blood pressure starts going down frequently before the heart rate drops precipitously, and then the patient passes out. And you can see that the cardiac output drops, and there's also a lowering in the total peripheral vascular resistance. Now, you could make almost anybody do this if you kept them on a tilt table test long enough, because this actual reflex is not uncommon. In fact, it's a normal reflex in some cases, but for some people, it's just very sensitive to this kind of thing or specific triggers. But sometimes this is helpful when you can't figure out what's going on and you want to try to make a diagnosis and try to link the symptom to what's going on with the patient. There's a problem with that too. Reggie Lewis played for the Celtics, and he passed out while he was dribbling down the court one day, and he was brought into the hospital, and one of his doctors said, let's do a tilt table test and see what's going on. Now, somebody doesn't normally have vasovagal syncope while they're dribbling down the court. He did have a positive tilt table test, but he also had ventricular dysfunction and non-sustained ventricular tachycardia. He had cardiomyopathy. And actually, he went back to playing ball, and he died suddenly in a pickup game. So here you have a tilt that was positive, but again, like any other test, it does not necessarily give you the diagnosis as to what is actually going on with that patient at the time that they passed out. So you have to link the history with what you find on the clinical evaluation. Now, going back to our patient from the beginning, a 52-year-old man wondering what happened. He was found on the street. He had sudden unexpected loss of consciousness. He had a normal physical examination. He had a normal EKG. He had a normal echocardiogram. And you reassure him, and he's thinking, I'm not reassured. I think I'm going to die. I mean, I was found on the street. Like, how did that happen? So we put him on a tilt table test. And on the tilt table test, he did fine. Until when I brought his wife in and just to let her know everything looked good, he took one look at his wife, he turned white and he became asystolic, and I had to do CPR on him. He had a 32-second pause seen right there. The tilt table test did not reproduce the clinical situations that may necessarily cause the triggering for his what appears to be vasovagal syncope. Now, the treatment for this may not necessarily be straightforward. But here you have a situation where you have a long asystolic episode. Then the question is, okay, so now what do you do? Well, he had one episode before. And the issue is, do you need to put a pacemaker in him? Is that going to even help? Because if he's vasodilated, is he even going to respond to the pacemaker? So there are some data on this. And a prolonged asystolic episode during a tilt does not necessarily mean that a pacemaker is necessary. In fact, many people that have had tilt table tests, as you see here, had asystole, and without a pacemaker after long-term follow-up, very few people had recurrent syncope. So pacemakers do have a role for vasovagal syncope, but for specific patients, not for everybody, and that's for sure. So the next issue is to assess this, to assess what that risk of recurrence is, and to assess the risk for death. Clearly an important issue, and as a cardiologist, and as a cardiology fellow, this becomes a critical issue to be able to distinguish what's going to happen with the patient. You don't want to have somebody come in the hospital who had a sudden loss of consciousness and then reassure them that everything is just fine, and they go home 3 days later, drop dead, because there are risks for some people, and even younger people. It could be a hypertrophic cardiomyopathy patient. It could be a patient with a long QT interval. It could be a Brugada patient. So there are all kinds of different situations that put people at risk for sudden death. And the real thing that we need to do is to be able to distinguish who is at risk for sudden cardiac death, or total mortality for that matter, versus who has a benign problem, and is that benign problem taken care of, or is it going to come back and we need to do something about it for the long term. So let's go back to the same diagram I showed you before. Try to figure out the cause for syncope. Try to determine if it's likely to be recurrent or not, and then consider risk for sudden cardiac death and total mortality for that particular individual. The EKG can be extraordinarily helpful. WPW may be seen, Brugada syndrome may be seen. You may have left bundle branch block or AV block or some other issue, and that will be very helpful to assess. Now, in the guidelines, the recommendation is fairly straightforward. If somebody is a low-risk patient, it looks like a typical reflex or vasovagal episode or situational episode, cough, syncope, or something like that, then probably can go home. But for those people that have high-risk features, of course, you're going to admit them and do a full evaluation as to what that risk is and assess that risk to determine if they need something else to be done. And then there's an intermediate group that can be very difficult to figure out. Just want to point out, in the guidelines, there are recommendations for those who are at highest risk and low risk. High risk, usually older age patients, ischemic heart disease, structural heart disease, valve disease, syncope with exertion, a key issue, even in an athlete who's younger. Syncope during exertion, as I mentioned with Reggie Lewis, is a critically bad thing to have. And if that happens, there's probably something seriously wrong. Not necessarily, but probably something seriously wrong. That also goes for congenital heart disease, abnormalities on the EKG, et cetera. And then there's a group that are at low risk, which are the younger age patients who have a typical prodrome and have specific triggers that may potentially precipitate the episodes. Like I mentioned, some particular situational episodes that could be triggered by coughing or micturition or deglutition or something of the sort. There are also other conditions to consider. Of course, there are cardiac conditions. VT can, of course, cause syncope. AV block, transient or continuous, can cause syncope. And one thing to keep in mind about VT and bradycardia, someone can actually have VT and pass out and come into the emergency room in VT, but they're awake. Because what happens is when you have a sudden change in heart rate, whether it be lower or higher, that is the time that the blood pressure tends to drop. And so if somebody has a heart rate of 80 beats a minute, and it drops down to 30, they may pass out from that. But on the other hand, if someone always has a heart rate of 30, they may be very stable in that heart rate, and it may not be the cause for passing out. But consider also issues with pacemakers or ICDs that may be malfunctioning, and you may need to interrogate the device. Consider ischemia, aortic stenosis, tamponade, hypertrophic cardiomyopathy, pulmonary embolus. I think this has been overrated, this pulmonary embolus issue, because I think it does cause syncope, but I don't know that everyone needs to have it ruled out. Aortic dissection can, of course, cause syncope, as can acute heart failure and changes in blood pressure. There are non-cardiac conditions to consider: anemia, GI bleed, and so there, and trauma, and pneumothorax. I've actually seen somebody who had a Hammond sign, actually had esophageal rupture and had air in the mediastinum that led to a kind of vasovagal reaction, but it was a serious I guess you could call it non-cardiac condition. The other issue is, when do you worry, and what do you worry about? So from the emergency department setting, it's going to be the short-term risk of less than or equal to 30 days, whereas we not only have to consider that, but we have to consider the long-term risk for individuals that have had syncope, including specific high-risk profile issues that are listed here, including structural heart disease, the presence of heart failure, and even palpitations may be of some concern. Exertional syncope, again, highlighting that as an important issue. And consider also the family history of sudden death. Interestingly, long QT interval syndrome with syncope does not necessarily mean, if someone else in the family has had long QT and this individual may be potentially at risk, it doesn't mean that they're at risk for sudden death just because somebody in their family died. But of course, it raises the concern. So, if there's a family history of some type of genetic condition, be wary that something else seriously may be going on. And again, physical examination can be helpful. Troponins in the proper individual may be helpful. And even BMP may be useful in some cases. There have been some data to suggest that that's helpful, but those data are not that strong necessarily. I also want to point out this. These are data from the SCUD-HEFT trial. The SCUD-HEFT trial is a trial of heart failure patients with ejection fractions of less than or equal to 35%. And these were well-treated, medically managed patients who were randomized in some cases to defibrillators, some cases to amiodarone, some cases to placebo. But what's interesting was these were patients that did not have syncope when they first started the study. However, some people did have syncope in the study, and actually it was quite common. There were 458 episodes in 356 patients in this study. But note that of these people that passed out, 24 of the total group had cardiac arrest and 44 had ventricular tachycardia, meaning that other causes for syncope can occur or maybe never figured out in people who have ventricular dysfunction and heart failure. Just because someone has ventricular dysfunction and heart failure does not mean that they are passing out from VT necessarily. Many of these people had defibrillators and they still passed out, and the cause was not VT. So we don't necessarily know in all cases. Of course, high on your list is going to be looking for an aborted cardiac arrest or VT. Now, this brings up another issue, and that is, what if you find someone is found down in the street and someone starts doing CPR on them and then they wake up? Was that really syncope or is that a cardiac arrest? So there's a lot of overlap in this situation. It can be difficult necessarily to distinguish what was considered a spontaneous recovery or if somebody actually benefited from CPR. Electrophysiology testing has some value. That value is only for select patients, such as ischemic heart disease patients, but it can detect SVTs as well, and you can ablate the arrhythmia. So there are various things that electrophysiologic testing has value to do, but this is not routinely done in patients who have syncope necessarily. Then let me talk a little about treating the problem. First of all, we have to figure out what we're treating, what the problem is, and then why we're treating this. Is it to prevent recurrent syncope? Is it to prevent death? Or is it to prevent sudden death? Of course, all of these things you'd like to do, but preventing one wouldn't necessarily prevent any of the others. So vasovagal syncope, the recommendation is, first of all, education about what's going on, and perhaps hydration with salt and fluid, and even some counter pressure maneuvers may be potentially helpful. Then for recurrent episodes, a variety of drugs have been tested. And these include midodrine, Florinef, beta blockers. Again, this is different between the guidelines. Some guidelines recommend beta blockers and others don't. But notice these are all class 2B, and even midodrine is a 2A. Recently, there has been some new data on SSRIs suggesting potential benefit, but all data on drug therapy are flawed in the sense that they've not been all that helpful. Again, we talked a little about this, about a patient who has asystole due to vasovagal response, about the use of a pacemaker. Pacemakers have some value. In fact, some of that value is placebo value, but there is some real value of pacemakers, but not for everybody with a vasovagal episode. And I'll show you why. Here, if you take a look at this strip, this is done on a tilt table test, and the nurse wrote out. So that's where the patient passed out. Notice the patient's in sinus rhythm. The patient was lied flat. And when the patient lied flat, became asystolic. But the patient was already out before the patient was asystolic. The patient had already vasodilated to the point of passing out before becoming bradycardic. So putting a pacemaker in this patient with a regular pacemaker would not necessarily prevent the syncope. Now, there are some new algorithms in pacemakers, the so-called CLS algorithm or the rate drop response algorithm, that may be very helpful to abort the episode, or at least help maintain some degree of cardiac output, but not everybody with vasovagal syncope, even recurrent episodes, are going to necessarily stop passing out because of a pacemaker. So these are the recommendations from the consensus document, and this is for people over the age of 40 who are having documented greater than or equal to 3-second pauses during clinical syncope or asymptomatic greater than or equal to 6-second pauses. This is given a class 2A. This is for older people, as I mentioned, who have recurrent and unpredictable syncope, and this is presumably the cause for syncope. And even in a younger person, occasionally, even in a pediatric patient who has asystolic episodes that continue to occur for some unclear reason and appear to be vagal, pacemakers may have some benefit. Again, there's not for everybody, and you can't say that it's going to cure the problem. But for some people, it actually works very well. So this is something to consider, but it's a very small minority of people who have vasovagal syncope. Of course, pacemakers have use in people with heart block that have syncope. Of course, second-degree heart block and third-degree heart block, but we're talking here about vasovagal syncope. But again, it depends on the issue. For patients who have clear-cut bradycardia that's symptomatic, that's not related to a vasovagal episode, a pacemaker has value. Now, that's what I just mentioned, that pacemakers have value based on the guidelines. When you don't know for sure, so you have a patient who comes in, a little bit bradycardic, maybe runs occasionally at night in the 30s, maybe has some pauses with sleep apnea, 6-second pauses, and you don't know, but you think there's no other reason that this patient keeps passing out. The first thing to do would be consider a loop recorder, but if you can't figure it out, or if it just seems that there's an association, but you're not sure if it's a causal relationship, a pacemaker may have some value. That's given a class 2A. Also consider, though, that for most defibrillators, unless the defibrillator has a pacemaker in it, and you're pacing it, if it's not a single chamber device that's set at 30, the reason you're putting an ICD in a patient with syncope is not necessarily to prevent them from passing out, although it may do that, but it's also to prevent them from dying from a potentially life-threatening arrhythmia. But consider also that if you have a patient with syncope who has an ICD, you may have to make specific restrictions in terms of driving. And this is also true for anybody with syncope, about specific restrictions in the long term, depending on the clinical condition. So another condition to consider is orthostatic hypotension. And orthostatic hypotension can either be due to a neurogenic cause, and by that I mean one of the so-called, what they call it, alpha-synucleinopathies. These are conditions of alpha-synuclein that lead to autonomic problems with sympathetic outflow, and that can be pure autonomic failure or Parkinson's disease. And in these kind of situations, when somebody stands up, the blood pressure just plummets. A lot of these people have hypertension when they're supine. This can also occur in diabetes, and they pass out. Then, of course, this could be due to drugs. It could be due to vasodilators or diuretics, and it can be due to dehydration in somebody who's younger for whatever reason. Maybe they ran a marathon and then they just stopped and they lied down and they stood up and they passed out. So that could be dehydration. So the treatment depends on what you think the cause of it is. And water is interesting. It's an interesting therapeutic intervention, even in neurogenic orthostatic hypotension, because when somebody gets water, within 10 or 15 minutes, the standing blood pressure can go up about 30 to 40 millimeters of mercury for a couple of hours just by drinking a glass of water. There seems to be something about the osmotic load of water that increases blood pressure. Other things to consider are compression garments, counter-pressure maneuvers such as crossing your legs, midodrine, which is an alpha stimulant, but that also will raise the supine blood pressure, droxidopa, which is a norepinephrine prodrug, which gets released presumably from the neurons, which seems to increase blood pressure when standing, and it can also raise blood pressure supine, but usually not as much as midodrine, and Florinef are some things to consider. With the drugs, of course, you're going to try to withdraw the drugs that are causing the problem, and if it's dehydration, of course, treat that problem. So I just want to conclude that syncope is a very common problem. I'm sure everybody on today, on this session today, is going to take care of many patients with this problem. And the real issue that we have is to really distinguish benign and situational episodes from those that are potentially life-threatening. And also consider that an unexpected recurrence can be devastating and lead to debilitation and can lead to restrictions. Of course, this is a problem in a truck driver or somebody else who has a job in which recurrent syncope would be a really bad problem, even if it's a benign issue. So the treatments are not, there is no specific treatment that would be considered a class 1 treatment that is a drug treatment for a neurocardiogenic syncope, but there are things that you can do to try to improve the chances of having episodes. And again, it depends on how frequent the episodes are. When it comes to syncope associated with a cardiac condition, and there are a variety of cardiac conditions, we didn't have the time today to talk about all of them. Sarcoidosis, just being an example, you can have infiltrative cardiomyopathy. You can have a variety of different kinds of cardiomyopathies and valvular disease and ischemic disease that can lead to syncope by a variety of different mechanisms, whether it be hemodynamic, or whether it be bradyarrhythmic, or whether it be neurocardiogenic, or whether it be ventricular tachycardia. But when you have a cardiac condition, there could be a poor prognosis. This isn't true for everybody with a cardiac condition. And again, depends on that cardiac condition. There are many cardiac conditions, and these are in the guidelines. If you'd like to look, there are some tables that go through some of the different types of cardiac conditions that are associated with syncope. But those episodes that are of syncope that occur with an underlying cardiac condition raises the risk for the individual. That is, if you have a cardiac condition, let's say Brugada syndrome without syncope, you're at lower risk than if you have Brugada syndrome with syncope. So syncope augments the risk of the underlying condition, requiring careful follow-up and then potentially treatment that could offset the risk, whether it be lowering the risk of sudden cardiac death or hopefully reducing the risk of total mortality, but at least helping to reduce the chance of recurrent syncope. Well, thank you very much for listening. I'd be happy to take any questions you might have on this topic.
Thank you, Dr. Olshansky. I think there are a couple of questions here. The first question is, what do you think is the mechanism of syncope in patients with right ventricular dysfunction?
That's very interesting. That's a very interesting question. You know, I was going to show you a video, but you know, for sake of time, I didn't, of a patient who kept passing out in the hospital and was actually got a video EEG because she looked like she was seizing. And so I had a movie of her actually seizing. And it turned out that what happened to her is she became very tachycardic and then all of a sudden asystolic, and her blood pressure dropped to nothing when she had any heartbeats at all. And it turned out she had primary pulmonary hypertension. So I think what happens in right ventricular overload, and this is also true with pulmonary emboli, I think what happens is you don't necessarily pass out from a pulmonary embolus or right ventricular overload from decreased flow into the lungs, because if that were the case, you'd never wake up. But what happens is they tend to be sudden episodes. When the right ventricle gets placed, the contractility increases, or there's sympathetic activation. What happens is you get a neurocardiogenic response frequently, a vasovagal type response. And again, not all vasovagal responses are necessarily benign, because if somebody has right ventricular overload and passes out, I think this could be an end stage type of situation that could be potentially life-threatening, yet it is vasovagal. In fact, I think this is probably the case in many patients with heart failure. We think about heart failure as a high risk for mortality, which of course it is. But in some cases, we can offset that risk with a defibrillator because we can prevent life-threatening ventricular tachycardia and ventricular fibrillation. However, there is a population, and in the heart transplant population, somewhere about 30% of people with bad heart failure die suddenly without ventricular tachycardia. So, and I've seen this quite often, where somebody just becomes asystolic. And I think when the heart is being beaten up essentially with catecholamines, it's trying to maintain cardiac output. And if it can't do it, it has this almost end-stage vasovagal response that probably leads to that. I think that's probably what may be going on for some of our patients who have had heart failure and cardiomyopathy. Thank you for the question.
Yeah, I think you answered a similar question also. But I just wanted to clarify for everyone, if you can just go over the CLS algorithm quickly. And there are some questions on CLS algorithm as well.
Okay, so I didn't go through the different trials, but there are, what's interesting is if you look at one of the original trials, the VPS1 trial, which is a rate drop response pacemaker trial, there was a huge benefit of a pacemaker compared to no pacemaker. But they began to realize for vasovagal syncope, that is Bob Sheldon who ran that trial, that there may be a big placebo effect. So he did the VPS2 trial where he actually put in a pacemaker in everybody and turned it off in half the people. So he got a placebo pacemaker and everybody got some benefit. There was still a real benefit of the pacemaker, but the problem is with the rate drop response, it's too little and it's too late. It takes a long time for it to work. But the Spain trial looked at CLS. So this is closed loop stimulation. And what this is the contractility of the right ventricle increases just before the vasovagal episode, and the blood pressure is starting to drop. So by what the tip of the lead measures is actually the amount of contractility, or the movement by impedance of the heart around the tip of the lead. And when it sees a change in that, it basically stimulates the heart, and it basically increases the rate early on, and therefore may offset some of the vasodilatation or the vasodepression that's occurring during a vasovagal episode. And that was the Spain trial, and that was a crossover trial, a placebo designed crossover trial showing benefit. And I do think in vasovagal syncope, I think the closed loop stimulation type pacing is the most likely to prevent recurrent episodes. So if you have a patient that's having a lot of bradycardia with episodes, and that can be also found on a tilt table test, I'd say the closed loop stimulation type pacemaker is the one to implant, as it likely will have more benefit than the other types of pacemakers.
A related question is, do you foresee that CLS will make its way into guideline document as pacing algorithm over rate drop response?
Yes, that's a great issue. You know, I think unfortunately, if you look at the pacemaker, I've actually seen in some cases where a micro pacemaker was put in for vasovagal syncope. A micro is basically is a leadless pacemaker and put in the ventricle. That really, to me, makes no sense at all, because what you need is AV synchrony for sure. But I think a regular pacemaker is not going to work very well for vasovagal syncope. But unfortunately, much of the early work was done with the rate drop response, which is where the rate goes down fairly quickly, and then the pacemaker kicks in. But again, too little, too late. So it was only recently that some of the data on the CLS algorithm has been shown to be beneficial, and I think it will get into the guidelines. I think this is going to be, I mean, as far as I'm concerned, if you think a pacemaker is going to work, this is the one to put in. And it's not really in the guidelines at this point, but this would be my recommendation at this point. And we've written some things about this. I think that's really the best way to go.
Next question I have is, what is the plausible mechanism for beneficial effects of beta blocker in vasovagal syncope?
Yeah, so this has been argued about, and people have so thank you for that question. People have very strong opinions about beta blockers. At one point in time, Dave Bendit was saying, this goes back maybe 20 years, where that patients that had a positive tilt should be put on a beta blocker, showing some benefit of beta blockers. Then beta blockers fell out of favor. Schra did some work, and some others did some work showing that the pacemaker, that it may be all placebo effect, that the beta blocker may be placebo effect. And that was based on the post trial that was done by Bob Sheldon. But it turned out that the people that benefited from the beta blocker were over the age of 42. So older people may have a different response than younger people when it comes to the vasovagal mechanism. And so how does the beta blocker work? Well, as I mentioned also in heart failure patients, when the heart is getting beaten up with catecholamines, it can trigger a vasovagal reflex. So how does that happen? So if somebody has a very high sympathetic activation, the heart, the receptors in the heart, the mechanoreceptors in the heart, are basically detecting increased contractility. And again, there could be many different mechanisms by which this vasovagal reflex occurs, but if it's related to the heart specifically, and the heart's contracting strongly, the mechanoreceptors are going to send signals up the vagal afferents into the nucleus tractus, and that's going to get processed in the brainstem, leading to sympathoinhibition and parasympathetic activation. So basically, the idea here is that by blocking the mechanoreceptor activation, by blocking increased contractility, that you would prevent that reflex. So it does appear to have some benefit, and that's the reason it got into the American Heart Association, American College of Cardiology guidelines, but that is not what the Europeans think. So the Europeans have given this a class 3, whereas in the American guidelines, it's considered like a class 2A, I think it is. And there's been maybe 2B, but it's been argued about. And all I can tell you is, in my own experience, I've seen beta blockers work. Again, How do I know it's not a placebo effect? Well, I don't know, but some people that I've had on beta blockers have been on other medications that have been ineffective, and the beta blockers seem to work. But I don't think as a routine that everybody should be placed on beta blockers for vasovagal syncope, because I don't think it's that great a therapy in general for that particular problem.
Next question is, does seizure cause any specific arrhythmia?
Yeah, great question. I mean, seizure, there is something called, it's SUDS, I think it's what it's called, a sudden unexplained death and seizure. So this is actually a big issue because people actually can die from a seizure. They can have ventricular fibrillation from a seizure. And they can have bradycardia hypotension from a seizure. I can give you an example of a patient who had, actually she came to me to be seen. She was seen someplace else, and she actually had a monitor done. This is a young woman who kept passing out all the time. And she had a monitor done that showed asystole during the episode. So she actually got a micro pacemaker because she didn't want to have a pacemaker. She didn't want to have anything on the outside of her chest. I mean, under the skin in the chest. So she kept passing out. So her father actually did a video EEG recording, and actually I got a little bit more history from her. She had this strange sensation, a strange smell before the episode. And looking at the episode when she was sitting down on the couch, it looked like a seizure. It first looked like an absence seizure, and then it looked like a regular seizure. And again, seizures, especially temporal lobe epilepsy and the like, can lead to bradycardia and hypotension. So seizures, there's a place in the brain, if you stimulate it, you can go directly into ventricular fibrillation. So you can, the sympathetic activation leads to ventricular fibrillation. So you can die from a seizure from sudden death. You can have a sudden death from a seizure. Some of the deaths that relate to seizures aren't related to arrhythmias. They're related to the seizure itself, but they could be related to an arrhythmia. And then there can be bradycardia and hypotension, that the vagal response due to the seizure. So it's important to get a good history, because what could look, sometimes it's not clear. Is it a seizure, or is it vasovagal syncope, or is it bradycardia due to sinus node dysfunction? Sometimes it's not so easy to figure all these things out. And history can help to some extent, but yes, indeed, seizures can cause a variety of different arrhythmias.
There are a lot of questions about risk scoring in these patients with syncope. I think there are a lot of risk scoring algorithms which are available. Any comments on that?
Yeah, I'm actually kind of flummoxed about the whole thing with this risk scoring. So thank you very much for that question. There's a lot to be said. There's a San Francisco rule. There are a variety of different kinds of rules that people have used. There are various Italian rules about looking at different things. But what it really comes down to is, do you have underlying structural disease or not? And they can actually, the San Francisco rule, basically the problem with a lot of these rules is that they're looking at the short-term outcomes. They're not looking at the long-term outcomes. And they're being designed mostly for emergency room physicians, because the emergency room physician clearly needs to know, what do I do with this patient? Admit or send home? And they don't want to admit someone that they don't need to, but they don't want to send someone home that's going to die. So they look at some of these rules, and some of the rules are a little bit strange, because they have listed on them anemia, they have listed on them non-cardiac issues, and of course, GI bleed can lead to a vasovagal episode, or it can lead to hypotension or orthostatic hypotension. And by the way, just to say something about that, about how GI bleed can lead to syncope. In an animal model, taking a dog, they've actually bled dogs many, many years ago and showed that they have vasovagal episodes from the bleed. Again, that probably leads to, increased mechanoreceptor activation, vagal afferent activation, and a vasovagal reflex, so to speak. Very much like a tilt. Does the same thing, because you get blood pooling in the legs. So all these rules have been developed, but it turns out that when you compare a competent clinician to the rule, and that's been done with the San Francisco rule, it turns out that a competent clinician does a better job. So until we get the right rule, I mean, and actually we're trying to work on something like that at the University of Iowa, trying to figure out a way to use AI to better understand, what are the issues to try to determine risks, short-term and long-term, in syncope patients, because it's a huge problem. Syncope is a huge problem in the emergency room, and it's going to be a huge problem for all of us because it's such a common issue. but we don't have great rules yet. That someone needs to hone those rules and make them better. But right now, the best thing to be is really a good doctor, and that seems to be about as good as you can be. So it's really being careful and complete in the evaluation.
Next question I have is if you can talk a little bit about the cardioinhibitory or vasodepressor response and how to interpret tilt table testing.
Great question. You know, the issue here is, and I didn't go through all the trials, like there's the issue 3 trial that looks at tilt table testing, and people have tried to use various VASIS, so-called the VASIS classification for responses, whether it be cardioinhibitory or vasodepressor. Here's my thought about this, and that is that just because you have one reaction one time doesn't mean it's going to happen the same way the next time. So the first time you see somebody and they become asystolic, next time they become hypotensive, or they become hypotensive and asystolic, or they become hypotensive first and then asystolic, or they become hypotensive and asystolic at the same time. It turns out that the tilt table test gets a different result than a loop recorder. In other words, and I had an example, again, I took it out because for time, but a young woman who had recurrent syncope and had a tilt, and she got a little bit hypotensive on the tilt, but really didn't pass out, and couldn't figure out what was going on with her, put a loop recorder in, and when she passed out, she had asystole. So it does turn out from the results of what happens clinically in real life compared to a tilt, you don't necessarily see the same thing because you're not doing the same thing. I mean, like the example I showed you where the guy's wife comes in. I mean, you know, whatever the triggers are in real life, they're not the triggers that happen on a tilt. People aren't tilting themselves to pass out. And, you know, the tilt only puts a stress on the heart, but you can pass out from pain. You can pass out from, you know, frontal lobe, activation. So it can be, various kinds of mental stresses, and they're not necessarily physical. So what's happening in the heart and what's happening on the tilt isn't what's happening in real life. So I don't know, again, the tilt is not perfect. There's no question about it, like any other test. But sometimes it has value in the patient where you really don't know what's going on, but you think you might know what's going on, and you really like to confirm that. And you don't think the person's at risk for sudden cardiac death. So there may be a value, but again, what happens on the tilt does not necessarily happen in real life.
Just a quick word on recommendations for driving in patients after first episode of syncope.
Yeah, and actually I would recommend everyone take a look at the American guidelines, because we spent a lot of time on this. And we really classified it fairly carefully. And Bob Sheldon in particular has done a lot of work on this. But this is a really tough problem because, you know, if somebody has one episode of what's clear-cut vasovagal, I don't get too worried about that. You know, if somebody has syncope of unclear etiology and you're concerned that they may have a cardiac condition, that changes things quite a bit. And it can be a real problem if somebody is a truck driver and they want to go back to work. And, you know, and so if you have a pacemaker, if you are pretty convinced that the episode of syncope is due to asystole or complete heart block, and this is not vasovagal, but just that's what the cause of it is, and you put a pacemaker in, and you're pretty convinced that that pacemaker is in a good position and it's working fine, as far as I'm concerned, in a couple of weeks they go back to driving once the time of healing is taking place. For a defibrillator, this of course is a big issue with commercial driving, and you know, you're not allowed to drive with a defibrillator. It can be a big, in fact, that's one reason sometimes people that are truck drivers won't even get a defibrillator because they won't be able to drive. But you know, because if they passed out, you know, is it safe for them to drive? It probably is safe. However, you know, from the National Transportation Safety Board or whatever it is, they're not going to clear them. So, you know, there are so many different ways to, but this is pretty clearly delineated as best as we could, looking at the data in the guidelines. It really is almost a case-by-case situation, but you know, everyone is a little bit different, but it's all pretty much in the guidelines as best we know from the data we have so far.
I know we're going over time, but I think there are a lot of good questions coming in. One question is, how do you treat patients who have orthostatic hypotension, but also have supine hypertension?
That's a great question. That's a really tough problem. And I think that's something interesting about this. I think that somebody is not necessarily hypertensive and then develops orthostatic hypotension. I think there's a relationship between the hypertension and the hypotension, because if your autonomic nervous system is all out of whack and you stand up and you're sitting up all day and you're hypotensive, your renin-angiotensin system is going to get activated. Your adrenaline is going to be released. You're going to resorb as much fluid as you possibly can. And so when you lie down, your tank's full and your blood pressure is going to go up. That's what I think is happening. So my experience has been, like I mentioned about the droxidopa, and I've used this quite a bit in those kind of patients, is that initially the blood pressure does go up a little bit in the supine position, but as the orthostatic hypotension gets better, the hypertension gets better. That doesn't happen with midodrine, because midodrine continuously tonically activates the alpha receptors, whereas with droxidopa, it does not do that. So I do think that there's a very close relationship between the hypertension and the hypotension, and that by treating one, you kind of treat the other. That's not always the case, but it's an issue. And some people do benefit from some ACE inhibition and also a drug like droxidopa to treat both hypertension and hypotension. But first, I try to treat the hypotension and watch the blood pressure carefully. But I do think that that's part of the disease entity. In fact, for most older people with that neurogenic orthostatic hypotension, I'd say 60% or so are likely to have hypertension associated with hypotension.
And one quick comment on that. Is there a rule to use nitroglycerin with tilt table testing?
Thanks for that question. It's a controversial issue. There are people who do that, and when you do, you're very much more likely to get hypotension and the vasovagal reflex. In fact, I've seen people have vasovagal reflex just getting a nitroglycerin, just in the emergency room. It does potentially trigger that. The question is, the sensitivity and the specificity. I mean, you may increase its sensitivity to some extent, but you make it non-specific. So then if you give enough nitroglycerin and you put someone on a tilt, eventually everybody's going to pass out. And so what have you really accomplished? You really haven't done very much. So, I mean, some people do it and actually recommend it. I'm a little bit more hesitant about that because of the concern of overdiagnosis of the vasovagal syncope, but I have occasionally done that.
Thank you very much, Brian. I'm going to take over at this point. Thank you. That was an excellent summary. The fellows really enjoyed it. We still have quite a few questions, so we will be sending that to Dr. Olshansky and uploading the PDF to our website as a link when we have it ready. So again, if you guys have questions about syncope, please keep sharing them on the chat window and we'll keep a track of it. Thank you very much, Brian. I'd like to move on to our next speaker at this time, Dr. Mazur. He'll be talking to us about ventricular tachycardia. Dr. Mazur is a clinical professor of medicine at the University of Iowa Carver College of Medicine and is an internationally known electrophysiologist. He's recognized for his expertise in the ablation of atrial fibrillation, ablation of ventricular arrhythmias, evaluation of MRI in patients with implantable electronic devices, and novel anticoagulation therapies for atrial fibrillation. His research interests are extensive. He's been involved in numerous clinical trials and published over 60 peer-reviewed manuscripts as well as 4 book chapters in key textbooks. He's a member of the editorial board of the American Journal of Cardiology and is reviewer for Journal of American Heart Association, Texas Heart Institute Journal, Heart Rhythm Case Reports, and Pacing Clinical Electrophysiology. I'd like to go ahead and let Dr. Mazur take over at this point.
Thank you, Mahi. Can you hear me? Hello?
Yes, we can hear you.
Thanks, Roy. First of all, I would like to thank Iowa chapter of ACC for organizing this educational session for fellow. And I'm really honored to be part of this program. So my topic today is ventricular tachycardia, and I don't have a conflict of interest to disclose. Here are learning objectives that I hope we will be able to accomplish today. I will discuss different types of ventricular tachycardia, their mechanism and prognostic implications, specifically with regard to the risk of sudden death. And finally, I will briefly review general recommendations, general principle and available data on the management of ventricular tachycardia. Something happened with my...
Yeah, Dr. Mazur, can you share your screen one more time?
Yeah.
Okay, let me see. Okay, here. Okay, here we
I think
are.
it's good now. Thank you, Alex.
So, and then finally, I will briefly review some general principles and available data on management of ventricular tachycardia in patients with cardiomyopathies. So, to start with, I would like to say that ventricular arrhythmia represents a clinical spectrum, including premature ventricular complexes, non-sustained ventricular tachycardia, and sustained ventricular tachycardia if it lasts at least 30 seconds and causes either syncope or hemodynamic compromise, and finally, ventricular fibrillation. These arrhythmias can occur either in the presence of structural heart disease or in patients without apparent structural cardiac abnormalities. The term idiopathic is relative and based on our current ability to detect structural abnormalities. Some of these patients may have subtle structural abnormalities that we're simply not able to appreciate at the present time. Channelopathies include arrhythmogenic syndromes such as long QT, Brugada, short QT, catecholinergic, polymorphic VT, etc. Patients with some channelopathies such as Brugada syndrome may in fact have some subtle structural abnormalities, including limited areas of fibrosis, predominantly in an epicardial right ventricle outflow tract, and also may have some cardiac functional abnormalities. I will not be covering channelopathies today in my talk, and with regard to structural heart disease, I will primarily refer to patients with ischemic and non-ischemic cardiomyopathies. Those are most common conditions that we deal on a daily in our daily practice. So, based on 12-lead ECG QRS morphology, ventricular tachycardia is categorized as monomorphic if there is a uniform beat-to-beat QRS morphology, pleomorphic if it has more than one distinct QRS morphology during same VT episode, and finally polymorphic when VT has variable beat-to-beat QRS morphology and continuously changing frontal plane QRS axis. Reentry is the most common mechanism of ventricular tachycardia. The underlying substrate for reentry can be anatomical, such as scar, fibrosis, or His Purkinje system. This type of reentry typically manifests as monomorphic VT. Functional reentry, including spiral wave reentry or three-dimensional type of reentry, so-called rotors, is believed to cause some forms of polymorphic VT and ventricular fibrillation. Another mechanism is triggered activity due to either early after depolarization or delayed after depolarization. Examples of ventricular arrhythmia ascribed to this mechanism are catecholinergic polymorphic VT, bidirectional ventricular tachycardia due to digoxin intoxication, or RVOT VT. Abnormal automaticity is a less common mechanism. An example of VT is VT rising from a partially depolarized peri-infarction myocardium. So idiopathic ventricular arrhythmia, with a rare exception, is usually a benign arrhythmia with low risk of sudden death, and a therapeutic approach is primarily symptom-driven, with some exception of a suspected arrhythmia-induced cardiomyopathy. Idiopathic ventricular arrhythmia most commonly manifests as PVC or non-sustained VT. It can originate anywhere, but the majority of ventricular arrhythmia tachycardias originate from some idiopathic ventricular tachycardia originate from some typical sites. The most common site is outflow tract, both RVOT and LVOT, including aortic sinuses of Valsalva, as shown here, aortomitral continuity, and also anterior perimitral left ventricle. Less common site include posterior perimitral and peritricuspid ventricular tachycardia, LV papillary muscles, moderator band, left bundle fascicles, and also a left ventricular summit, which is the most superior epicardial part of the anterior anteroseptal left ventricle, adjacent to the aortic valve, which is usually accessible from for ablation only through the coronary sinus venous system. ECG is a very useful tool to determine the site of origin. This is very important for defining a therapeutic strategy, particularly to inform the risk and the success of the ablation procedure. For example, ablation of RVOT-VT is a relatively low-risk procedure with high risk, with high success rate, and definitely can be offered as a first line approach. On the other hand, ablation of epicardial summit VT is technically more challenging with a limited success rate and potential risk of serious complications because of very complex anatomy in this area and limited access to the also limited access to this area, and also proximity of the major coronary arteries. Ablation of papillary muscle VT it might also be challenging, since some of them may originate deep within this relatively thick myocardial structure and may not be readily reachable with currently used ablation technologies. Here is an ECG example of outflow tract VT. This is the most common type of idiopathic VT, as I mentioned before. This is just an example to show you how to use ECG to determine the site of origin of ventricular tachycardia. Outflow tachycardia, ventricular tachycardia characteristically has inferior axis with positive QRS complexes in leads 2, 3, and AVF, because the arrhythmia originates in the most basal part of the ventricles, and the activation vector is directed to the positive electrode in these leads. If VT originates from the right ventricle, then there would be a left bundle branch block QRS pattern with relatively late precordial QRS transition, usually at lead V3 or even later. Left ventricular outflow tract arrhythmias, tachycardias can have either LBBB or RBBB pattern, depending on the origin. In general, R wave become progressively larger and wider in lead V1 when origin shifts leftward from septum to anterior mitral annulus. In LVOT arrhythmias with LBBB pattern, like in this case, for example, the precordial transition typically occurs before lead V3, and as you can see, that transition, precordial transition in this lead is relatively early between lead V2 and V3, suggesting LVOT origin relatively closer to septum, probably in the area of the sinuses of Valsalva. VT structural heart disease usually originate from the area of the scar. It's very important to remember. And the most common mechanism is scar-related reentry. And our current understanding of the underlying substrate is that viable myocardial bundles within the scar create a network of slow conducting channels within the region of anatomical or functional conduction blocks that cause reentry, and as shown in this schematic. Ventricular tachycardia due to scar-related reentry is typically monomorphic, but can be rarely pleomorphic because of changing exit sites, usually in patients with ischemic cardiomyopathy. We see this phenomenon. The QRS morphology of VT is determined by the location of the scar and VT exit sites. The area of the scar and the number of potential channels can be quite extensive. So it's not uncommon to see multiple VT morphologies in patients with cardiomyopathies, particularly in patients with ischemic cardiomyopathy. This is an example of monomorphic ventricular tachycardia, scar-related monomorphic ventricular tachycardia. You can see very wide abnormal QRS complexes with consistent beat-to-beat QRS morphology. Differential diagnosis on EKG of monomorphic ventricular tachycardia includes SVT with aberrant conduction and also SVT using conducting over an accessory pathway to the ventricles. And there are some different algorithms to perform the differential diagnosis on EKG. Here, I just want to, there are multiple algorithms that you can find in the literature. These are classical Valence ECG criteria for diagnosis of ventricular tachycardia. Dr. Valence from Maastricht, Netherlands, one of the pioneers and icons of cardiac electrophysiology. So the strongest VT criteria are AV dissociation with less A than V, capture and fusion beats, negative or positive precordial QRS concordance. And concordance refers to polarity of QRS complex and precordial leads. When they are all positive, it is called positive concordance and vice versa. Tachycardia QRS duration, tachycardia QRS duration more than in sinus rhythm would strongly support ventricular tachycardia, since in aberrant conduction, usually with the tachycardia, QRS gets wider. Unfortunately, all these criteria are not always present. Analysis of the morphology of the QRS complex is also very useful. In general, RBBB or LBBB QRS configuration is determined by QRS morphology in lead V1. VT with RBBB morphology has a dominant R wave in lead V1, and LBBB morphology has dominant negative or S wave. In VT with RBBB configuration, characteristic QRS morphologies in lead V1 include QR, R, usually monophasic R, or R with a very characteristic downslope notch, so-called rabbit ear morphology. As you know, RBBB QRS pattern due to aberrant conduction in lead 1 is V1 is typically triphasic R with deep S and R prime. Deep S in lead V with 6 would also suggest ventricular tachycardia. In contrast, in RBBB, there is typically large R and small S in lead V1. S is usually wide rather than deep. So in VT with LBBB configuration, the presence of right axis in the deviation in the frontal plane would strongly suggest VT, because typical LBBB usually has normal or left axis. Relatively wide initial R in lead V1, more than 30 milliseconds, is slurring or notching of the downstroke of the S wave in lead V1, V2, as you can see here, or duration of from the beginning, timing from the beginning from the onset of the QRS complex to the nadir of the S wave in lead V1, V2, more than 70 millisecond. All these criteria basically suggest very, very slow initial activation, which would be not very typical for activation over the a rapidly conducting His Purkinje fibers. In contrast, in the typical LBBB, there is usually very sharp initial deflection in lead V1 because of fast activation of the right bundle, and only then QRS start to widen. Therefore, it's typically there is typically small and very narrow R in lead V1, and the timing between the onset of the QRS complex and S to the S nadir is typically less than 70 milliseconds. The presence of Q waves in lead V6 also would suggest ventricular tachycardia mechanism. Here is an example of VA dissociation. As you can see, regular wide QRS tachycardia with P wave marked as with arrows, marching through at a relatively slow rate. And you also can notice relatively narrow QRS complexes marked by the stars that are preceded by P waves here. And these QRS complexes are consistent with fusion beats between sinus and VT QRS. Also, you can notice that monophasic R wave morphology in lead V1 and relatively deep S wave in lead V6 would be also consistent with ventricular tachycardia. So here is another example of scar-related monomorphic VT with intermittent, relatively premature and narrow QRS complexes marked with arrows suggesting fusion beats. Once again, there is a large and monophasic R wave in V1 with characteristic downstroke notch, which is called rabbit ear pattern, and also you can see very deep S waves in lead V6 would also suggest ventricular tachycardia mechanism. Here is an example of VT with LBBB QRS morphology. There is a relatively wide R in lead V1, and with time from the onset of the QRS complex to the S nadir. Nadir is in lead V1 is more than 70 milliseconds. Also, you can see Q wave in lead V6 that would also support ventricular tachycardia mechanism. Here is an example of a negative QRS concordance. All QRS complexes are negative in precordial leads, which is one of the markers of ventricular tachycardia on EKG. His Purkinje system is increasingly recognized as a source of a different type of ventricular arrhythmia, and also may play an important role in the mechanism of ventricular fibrillation. There are two types of monomorphic ventricular tachycardia involving his Purkinje systems that I would like to mention specifically. First is a bundle branch reentrant ventricular tachycardia, a macro reentry arrhythmia involving left and right bundle branches. Most common circuit is when antegrade activation occurs over right bundle, and retrograde activation over left bundle. Since earliest activation in this case would be shown with the star, would be in the area of the right bundle, VT has usually left bundle branch morphology, like shown in this case. The reverse circuit will produce RBBB morphology, which is relatively rare. It's important to note that QRS morphology on ECG may be absolutely indistinguishable from a typical left bundle branch block or right bundle branch block, because ventricular activation occurs through the his Purkinje system. In the electrophysiology study, his bundle is typically recorded prior to each QRS complex, and with antegrade activation of right bundle, like in this case, or left bundle, depending on the direction of the circuit. Bundle branch reentry VT requires severe interventricular conduction disease. That's a VT of a conduction system disease. And most patients have underlying structural disease, and many have other types of arrhythmia, and may require ICD. Rarely this arrhythmia can be seen in patients without structure, with a structurally normal heart. It's important mechanism of ventricular tachycardia in patients after aortic or mitral valve replacement, since these structures are very close to the central fibrous body and his Purkinje system anatomically. And the damage of the conduction system is very common, also complication of the TAVR. It's important to be aware about this mechanism of ventricular tachycardia as potential underlying cause of syncope in patient after TAVR. The tachycardia is usually very fast, faster than 200 beats per minute, and typically manifests as syncope and may cause sudden death. We have seen 2 cases of this arrhythmia in patient after TAVR. So that's very important to know, and I believe, you know, we're going to see this more and more since there is a extending indication for TAVR nowadays. Ablation of a bundle branch, typically right bundle branch, is curative procedure and is considered the first-line therapy for this tachycardia, and medications are usually ineffective. Another mechanism, another type of tachycardia is fascicular ventricular tachycardia, or so-called verapamil sensitive fascicular ventricular tachycardia, or some people call this Bell-Hassan tachycardia, who first described response of this arrhythmia to verapamil. This is an idiopathic and relatively benign arrhythmia, often exercise-related, typically present at ages 15 to 40 years, and more common in men than in women for some reason. Usually manifest as palpitation, rarely may cause syncope. The mechanism is macro reentry involving abnormal Purkinje system, and left posterior fascicle is most commonly involved, like shown here. And thus the VT morphology is typically RBBB with superior axis. Rarely it involves anterior or septal fascicles, and in this case with the the frontal plane axis, QRS axis would be different, either inferior or normal. And as you can see here, the QRS is very, very narrow. Presence of VA dissociation is this case, shown with a P wave, shown with arrows, help to diagnose, to make the diagnosis, but occasionally it's easy to confuse with SVT when there is a VA association or P wave are not readily visible. And also this arrhythmia response to verapamil, which is not typical for VT, that may be confusing. Oral verapamil or diltiazem are drugs of choice, but not consistently effective, and ablation procedure is a highly effective, usually a second-line option. An important arrhythmia to recognize is a short couple variant of torsi de pois. We had actually 3 patients over the last few years, and all of them were misdiagnosed as long QT syndrome. So this arrhythmia was first described by Philippe Comel group from France in early 90s. The characteristic features are that it usually occurs, it always occurs in the setting of normal QT interval and triggered by PVCs with extremely short, like you can see here, coupling interval. And typically PVCs are unifocal with the same QRS morphology. This arrhythmia is a variant of idiopathic ventricular fibrillation in patient with structurally normal heart and should not be confused with long QT syndrome. It is associated with a very high risk of sudden death and require ICD placement. The problem is that many of these patients end up with multiple ICD shocks, and antiarrhythmic medication usually don't work, with exception of verapamil, which is also variably effective. Here is original manuscript by Philippe Comel in circulation. It has been subsequently shown that ablation of PVCs triggering polymorphic VT or VF can effectively prevent recurrence of arrhythmia and ICD shocks in majority of these patients. Interestingly, most of these PVCs triggering VT and VF originate from the Purkinje system, very rare from outflow tract. The PVC ablation approach was pioneered by Michel Asseguer from Bordeaux, France. As you know, Michel also pioneered pulmonary vein isolation for atrial fibrillation. Some of these cases described by Michel Asseguer seems to be very similar to what was described by Comel, a short couple variant of torsi de pois. The postulated mechanism of this arrhythmia is either triggered activity or micro reentry within abnormal Purkinje system. And this arrhythmia has now been described not only in patients with apparently normal heart, but also in multiple etiologies involving Purkinje system. Our fellow Dr. Matto recently published a case of Purkinje PVC triggered PVT in patient with sarcoidosis. PVC triggered PVT, polymorphic VT and VF can occasionally occur after myocardial infarction and may result in a VF storm. In these patients, PVC are typically mapped to Purkinje system at the border of the scar. It has been shown in animal models that Purkinje fibers are more resistant to ischemia than myocardial fibers. Here is a classical torsade deploy in the setting of in patient with long QT, congenital or acquired long QT syndrome. In contrast to short coupled torsade deploy, QT interval is usually significantly prolonged, as you can see here, with abnormal T and U wave morphology. And then also the coupling interval of PVCs is relatively long because of prolonged repolarization of this patient. And there is also very typical for torsade deploy, very characteristic short, long, short initiation pattern. You have to remember this short, long, short for torsade deploy. The typical torsade deploy usually manifests with this initiation pattern. Another potential specific variant of polymorphic VT is so-called bidirectional ventricular tachycardia with characteristic alternating QRS morphology and a frontal plane axis, as you can see here. Typically exercise-induced. This arrhythmia is due to abnormal intracellular calcium handling. The mechanism is believed to be triggered activity due to delayed after depolarizations. Some experimental data suggests that it may this arrhythmia may also originate from hyperkingitic tissue. Bidirectional VT is usually seen in patient with is a typical for a patient with catecholinergic polymorphic VT, which is an inherited arrhythmia syndrome due to mutation either in ryanodine or calsequestrin genes. In a catecholinergic polymorphic VT, treatment includes beta blockers, flecainide. It's very important to remember flecainide because it's probably going to be on your board. And flecainide is a sodium channel blocker that also blocks ryanodine receptors, and that's a major mechanism why it's so so effective in this type of the arrhythmia. Sympathetic denervation is a very effective option in drug refractory cases, and we've had 2 cases with sympathetic denervation in these patients. And the role of implantable defibrillator is debatable. Bidirectional tachycardia VT has also been described in patients with digoxin intoxication. So it's also this pattern is also very important to remember. So now I would like to spend a few minutes talking about management of ventricular tachycardia in patients with ischemic and non-ischemic cardiomyopathies. First, it's important to remember that sustained ventricular tachycardia in patients with cardiomyopathies is associated with increased risk of sudden death, unless there are some reversible causes. And it even hemodynamically tolerated forms of VT are associated with increased risk of sudden death. And as a rule, documented ventricular tachycardia is usually indication for ICD, unless there are some reversible causes such as electrolyte abnormalities, drugs, or in the setting of acute myocardial infarction. And ICD is the only proven modality that prolongs survival in this patient. But ICD can effectively terminate VT, but doesn't really prevent it. And recurrent VT frequently requires ICD shocks. And you know that frequent ICD shocks are painful and may cause significant morbidity due to psychological issue in these patients. Therefore, many of these patients require antiarrhythmic drugs or catheter ablation to minimize VT recurrences and ICD shocks. Antiarrhythmic drugs. The role of antiarrhythmic drugs in patients with cardiomyopathy and recurrent VT is usually limited to as adjunctive to ICD to minimize the risk of ICD shock. There is no data that they improve survival in this patient, with exception of beta blockers, which, if you would call this antiarrhythmic drug, they're only all antiarrhythmic medications are only marginally effective and have a very narrow therapeutic window with risk of proarrhythmia. Also, the discontinuation rate is fairly high because of intolerance and side effects. Class 1 antiarrhythmic medications are contraindicated because of their negative inotropic properties and the possible risk of proarrhythmia. As you remember, in the famous CAST studies, they were class 1 antiarrhythmic medications were associated with increased mortality. The study was done in the 80s, mid-80s. Amiodarone and sotalol are only guideline recommended medications. As you know, amiodarone is the most effective and most commonly used antiarrhythmic medication, but it also has long-term cumulative toxicity, and there are some concern of increased DFT threshold, defibrillation threshold on this medication. And defibrillation threshold is a minimal energy required to defibrillate ventricular fibrillation. Sotalol may potentially worsen heart failure in patients with advanced cardiomyopathy and should be used with caution in these patients. We occasionally use dofetilide off-label. It has never been approved for this indication. And in fact, a randomized controls, placebo-controlled study comparing dofetilide to placebo for prevention of ICD shock that was conducted by Pfizer showed neutral results and has never been actually published. Mexiletine is a class B sodium channel blocker, has a very limited efficacy, usually used in, we usually use in combination with amiodarone and rarely with sotalol. Ranolazine is an anti-anginal drug. Its major electrophysiological effect is the block of late sodium current. As you know, traditional sodium channel, class 1 traditional sodium channel blockers block early sodium current. Recent randomized placebo-controlled rate study showed very marginal efficacy of ranolazine in preventing ICD therapies, mostly ATP. There was no really effect on mortality. So recent meta-analysis of randomized trial comparing antiarrhythmic medication with standard medical therapy and with standard medical therapy in patients with ICD showed that only amiodarone showed significant reduction in VT recurrences by in aggregate 70%. And as you can see here, all antiarrhythmic medication showed no significant impact on mortality. So there is no really routine indication for this medication in patients with ICD except for prevention of recurrent ICD shocks. Catheter ablation. In general, catheter ablation of ventricular tachycardia is currently considered as a second-line approach when antiarrhythmic medications, either amiodarone or sotalol, fail to control recurrent VT, or antiarrhythmic medication or are intolerant or not desired in patients with both ischemic and non-ischemic cardiomyopathy. In select patients with ischemic cardiomyopathy and hemodynamically stable monomorphic VT, ablation can be considered as a first-line approach. But that has to be discussed on a case-by-case basis. Similar to antiarrhythmic drugs, the role of catheter ablation is adjuvant to ICD in order to reduce symptomatic burden of ventricular tachycardia. And once again, there is no proven survival benefit of catheter ablation in these patients. This is a very important study, recent study from Canada called VANISH. That's abbreviation for ventricular tachycardia ablation versus escalation of antiarrhythmic drugs. The study addresses a common clinical scenario when patients treated with antiarrhythmic drugs continue to have recurrent ICD shocks for VT, and what would be the next step? Escalation of antiarrhythmic therapy or ablation procedure. The study enrolled 259 ICD patients with ischemic cardiomyopathy and recurrent VT despite antiarrhythmic medications. And these patients were randomized to either escalated antiarrhythmic regimen or VT ablation. And the escalation protocol was designed according to the baseline antiarrhythmic regimen. Patients who were amiodarone naive were started on amiodarone. Most of them were initially treated with sotalol in this study. And those patients who had already been on amiodarone, the dosage of amiodarone was increased to more than 300 milligram a day, or they received a combination of amiodarone and amoxicillin if they were already on a high dose of amiodarone. The primary endpoint of the study was a composite of death and appropriate ICD shocks for VT-OVF. And as you can see here on this Kaplan-Meier curves, that rate of primary endpoints event were quite high in both groups, but significantly lower by 28% in patients who underwent ablation. So ablation was superior to escalation of antiarrhythmic therapy, and the difference was primarily driven by reduction of VT recurrences in the ablation group. When the primary endpoint was analyzed separately, according to the baseline antiarrhythmic regimen, the benefit ablation was only seen in patients who had recurrent ventricular arrhythmia despite treatment with amiodarone. There was no difference in patients who were switched from sotalol to amiodarone. And the major message, in my view, is that from this important study is that if ventricular arrhythmia recurs on amiodarone, we should consider in patient with ischemic cardiomyopathy, we should consider ablation procedure as the next step. On the other side, in amiodarone naive patients, both amiodarone and ablation seem to be reasonable options, and decisions should be made on case-by-case basis. And this has been reflected in a recent expert consensus statement on orchestral ablation of ventricular arrhythmia published a couple of months ago. Another very important point to remember is that most common mechanism of monomorphic ventricular tachycardia in patients with cardiomyopathy is scar-related reentry. And therefore, as you can see here, in patients with ischemic heart disease and sustained monomorphic VT, coronary revascularization alone is an ineffective therapy to prevent recurrent ventricular tachycardia. So the decision about revascularization in this patient should be individualized, but the most important point is this most likely is not going to help for monomorphic VT. So if patient comes with monomorphic VT, revascularization alone is not enough to treat this patient. So this is a flow chart that summarizes approach to patient with an ICD and recurrent ventricular arrhythmia, and that's I already went through the most of these points, but what I would like you to what I'd like to emphasize is to note is the emphasis on VT morphology. How do you approach this patient? In polymorphic VT, it's important to rule out reversible causes such as ischemia, drugs, electrolytes, and monomorphic VT is substrate base arrhythmia. And my final slide and takeaway points is that idiopathic VTs are usually benign, particularly monomorphic VT, and the approach is primarily symptom-driven. The most common mechanism of monomorphic VT in patients with structural heart disease is scar-related reentry, and this type of VT in patients with structural heart disease would unlikely to be related to a reversible cause. Sustained VT in patients with cardiomyopathies is associated with high risk of sudden death, and if it's not related to a reversible cause, is indication for an ICD. ICD is the only proven modality to reduce sudden cardiac death in these patients. And finally, the role of antiarrhythmic medication and ablation in patients with an ICD is prevention of recurrent ICD shock. There is no proven mortality benefit. Thank you very much, and stay safe.
Thank you, Dr. Mazur. I think we have some questions here. The first one is, how can we reliably differentiate fascicular VT from SVT on a 12 lead?
Yeah, that's a great question. That's what I mentioned before. It's sort of a pattern recognition. You have to be aware about if there is if there are right bundle branch block, that's the most common type. Right bundle branch block, either superior axis, probably more than 95% of cases is superior axis, and sometimes inferior axis. So you have to sort of be aware about this potential mechanism. And as I showed in my slide, you know, you have to look for AV dissociation, but otherwise, you know, that's a mechanism. If VT is the QRS is very narrow, and P waves are not very visible, then it might be difficult to do. Most patients with SVT today are referred for electrophysiology studies. So then when you refer those patients for electrophysiology studies, so you have to be aware that that might be the case. Especially if you don't have any RBVB or some other intraventricular conduction abnormalities on surface EKG and sinus wave. All right.
I think you already answered, but there was a comment. If you can comment on timing of ICD in patients presenting with VFib.
Ventricular fibrillation.
Yeah.
Well, the timing is, if there is, if you believe that there is no reversible cause, this patient should not be discharged from the hospital without ICD. That would be timing. That's a secondary prevention device. And if there is no really readily identifiable cause, like as ischemia, drugs, or something else, they need to get ICD. And then if there is an idiopathic VF, like one of that I showed, very, very rare cases, and there is no clearly identifiable cause, then those patients needs to get ICD. But the major point is to recognize this specific variant of polymorphic VT, and most of them have polymorphic VT and VF. Most of them are PVC triggered, and PVC ablation is the only effective way to treat these patients. We described one case when patient didn't have a lot of PVCs to map. We did sympathetic denervation, and it worked perfectly. But again, there is no much data about this.
I think you answered the next point. There was a comment as how do you approach scar-related monomorphic VT that is triggered by PVCs from ischemia? So thank you.
Again, the monomorphic VT should be, in patient with monomorphic VT, the ischemia trigger would be probably less likely mechanism. In my experience, if patient come with sustained monomorphic VT and have ischemic cardiomyopathy, this ventricular tachycardia is going to be recurring on and on. Either depends on what is patient on, if antiarrhythmic medications or ablation procedure, would be two options in addition to revascularization. But I would not, and clearly those patients needs to get defibrillator. But I would not probably, as a first step, I would implant defibrillator and maybe start, if patient is antiarrhythmic drug naive, I would start them on sotalol, and if sotalol doesn't work, then we can discuss ablation procedure or amiodarone.
Next question I have is what is the recommended maintenance dose of amiodarone in patients with VT? Is it 400 or 200 daily? And if there's any benefit in initiating higher maintenance dose in some patients?
That's a great question. There is no really recommended dosage, and we know that. So in my experience, if 200 milligram doesn't work, the 400 milligram or higher would the incremental benefit would be not very high, but there would be probably higher risk of side effects. So if patient fails 200, if amiodarone 200 milligram fails to control recurrent ventricular tachycardia, has been shown in Vanish study, further escalation of antiarrhythmic therapy, escalation of dosage of amiodarone would unlikely to work. So, my personal approach would be to consider ablation procedure in these patients.
I think one clarification people wanted was with clear-cut monomorphic VT and no chest pain, but the patient has known ischemic cardiomyopathy, would you still push for ischemic evaluation?
Oh, that's a very great question. I guess, that's I don't know personally. There's in the guidelines, if you the recent consensus document, the ischemic workup in this patient is considered not unreasonable based on expert opinion. There is no data about this to just evaluate for ischemia burden in case if just to out of concern that patient may, if he or she has relatively large ischemic burdens, they may crash on the table when you do ablation procedure. That evaluation prior to ablation procedure. If I plan ablation procedure, sometimes we do ischemic workup if there is no recent functional studies or something, just to make sure that there is no really a significant and a large amount of myocardium that may be jeopardized. So that's just to, in case we plan ablation procedure to prevent significant ischemia during ablation procedure. But again, if you ask me, is there any data about this to do this routinely? There is no. And I think, we usually do this on case by case. And if I consider antiarrhythmic medication as a first approach, and patient doesn't have any evidence of acute evidence of ischemia, then I probably would not do ischemic evaluation. Roy.
I think we're good here. Thank you, Dr. Mazur.
Oh, thank you very much to everybody, and thank you, ACC Iowa chapter again.
Thank you very much, Alex. Excellent talk. I think it was very informative for everybody. Again, if there are further questions, we might send you an email and then get those responses up on the website. But I think we got most of those answers. Thank you very much again for your talk this week and last week. Very informative. I'm going to move on to our third speaker for the day, the third and last but not least, Dr. Troy Rhodes. Dr. Rhodes is a clinical associate professor at the University of Iowa Hospitals and Clinic. He received his MD from Eastern Virginia Medical School and his PhD in neuroscience from the same place and Old Dominion University. He did his internal medicine residency and cardiovascular fellowship training at Vanderbilt, and he trained in cardiac electrophysiology at the Ohio State University Medical Center. Prior to joining the University of Iowa, Dr. Rhodes has worked at the Ohio State University Medical Center and the University of Mississippi Medical Center, where he served as EP Fellowship Director. He joined the University of Iowa faculty in 2016. He's certified cardiac device specialist, fellow of the Heart Rhythm Society, and his clinical interests include electrophysiological testing, ablation of SVT and VT, and other ventricular arrhythmias, device implantations, lead extractions, and the evaluation and management of syncope. He's going to be talking to us about EKG interpretation and coding. This is session number 2, and I will let Dr. Rhodes take over.
All right. I think that kind introduction. So what I'm going to do today is talk about EKG coding. This is a similar lecture that I've given at both Ohio State and University of Mississippi. And so what we're going to do today is, let's see, I've lost, oh, there it goes. So just, I have no disclosures related to this talk. I do serve on a business strategy advisory board for Boston Scientific, but nothing related to this talk. So one of the things as you're reviewing EKGs, the thing that really prepares you for boards is the coding sheet. This is the paper version of when, like for example, when I took boards, we had basically had to code everything, basically on paper. What they've done is they've converted this into the online test. So if you go through, you have general features and P-wave abnormalities. Okay, then you go through the rhythm, AV conduction, what's the voltage, interventricular conduction, is there any presence of Q-wave MI, are there any ST, T-wave changes? And then something that's very important is, does this EKG match a clinical disorder? And finally, what's pacemaker function? So if we go back, everything that you need to code is on this sheet, okay? So I probably, as you're preparing, as you're coding EKGs, as you're basically going through, I would kind of use this as a guide just that you know where everything is and kind of get into that mindset. The tips that I've kind of come up with in terms of how to prepare fellows for the EKG coding portion of the test is that you're really looking for 3 to 4 major and minor diagnoses. There's a tendency to overcode that does not tend to be helpful. You're more likely to lose points. And remember, the way the boards are set up, if you fail the EKG part, you fail the boards. That's how critical EKG coding is. So it's important to be systematic and speedy. And I think it's good to have, as an EP, we tend to think anatomically, and we think, so we tend to think, basically in progression. But I would probably have an approach where, what are the atria doing? What's the AV node doing? What's the conduction system doing? What's the ventricle doing? Another key step is to look at your rhythm strip. 2 different things could be happening on the left side of the EKG, and then something completely different could be happening on the right side. So are there changes? So, they give you the rhythm strip, and a lot of times they'll give you 3 of the rhythm strips to look at just so that you can have the best chance to identify what's exactly going on. You don't make a diagnosis and you're just looking at the inferior leads. Okay, look at everything and really spend time on your rhythm strip. Don't get stuck, move on, flag and come back. Okay. Something that I'm not, kind of advertising, something I feel very helpful is what's called the EKG criteria book. It's basically the baby O'Keefe. It's part of the larger O'Keefe in the back, but as a pocket book, they do put out a pocket book that basically goes through all coding. It's very good because it gives you an example EKG. It may just be 1 or 2 leads, but it's very good to basically, here's what you're looking for. I think it's very important when you're looking at the clinical disorders to get all the diagnoses that build up to say, yes, this goes with, for example, hypokalemia. Okay. An area that has created some confusion just because there isn't a lot of consistency with the various EKG coding in terms of books or online if it's EKG source is when it comes to MI coding. And so when they're looking for ischemia, when we think about ischemia, what we're looking for on the EKG is ST depression, T wave inversion, but Q wave should be absent. Okay, so we're looking at ischemia. Now with injury, you're looking for ST elevation and your Q waves should also be absent. Now with infarction, you're looking for abnormal Q waves. There could be ST depression, there could be ST elevation. Depending upon the progression and the stage of the infarction, you may have T wave inversions, you could have normal T waves, or they could be upright and peaked. When it comes to the coding sheet, when it comes to coding MI, you really only have 2 timing options. Is this acute or recent, or is this indeterminate or old? Okay, and then within that, they want you to localize the injury pattern. Okay, is this an anterior? Is this inferior? Is there inferior with posterior involvement? Now, the way I have historically taught coding for MI is really based on discussions I had when I was at University of Mississippi. The chairman of medicine at that time, Dr. Little, interventional cardiologist, he was on the ABIM writing committee, and there's a lot of confusion about how the fellows were coding when they were using EKG source, and that really came out when I was giving them EKG tests to kind of see how they were doing. In discussion with Dr. Little, the writing committee, at least at that time, felt like they really wanted you to identify injury and then localize the ST elevation in terms of injury. And then the only way to localize that is to basically code an acute MI. So you would code ST elevation, consistent with or suggesting myocardial injury, but then you would also localize it by saying, acute inferior, acute anterior. So that was kind of the expectation. Historically, that's the way that I've kind of instructed fellows to code MIs. Because clinically, when we do it, when we code an EKG, we're coding acute inferior STEMI. Okay, that's kind of the way we clinically do it. So on the board exam, they do want you to recognize an injury pattern, but they also want you to localize it. And the only way to really do that is to code, even though a Q wave isn't present, you're basically saying this is an acute inferior posterior MI. Okay, so what I'm going to do is we're going to kind of work through some EKGs. Some of the Iowa fellows, I hope, will recognize some of these. But what I'm going to do is put up an EKG, give you a little bit of time to look at it, and then we're kind of going to work through it in terms of the major diagnoses. So this is a 51-year-old woman, and she presented with palpitations, and with those palpitations, she was experiencing chest pain. All right, so hopefully everybody's had a chance to look at this, and I hope everybody's thinking that this is some type of SVT, okay? It's clearly narrow complex, okay? We really don't see clear P waves. There may be some notching here, but we're really not sure, okay? The other thing that we'll look at is we'll look at V1, and there may be some notching, okay, or there may be a pseudo R prime in V1, okay, but we clearly have SVT, okay. The other thing with SVT is that we have pretty profound ST depression, okay. So another thing that they're going to look for coding is basically ST and T wave abnormalities, consistent with ischemia, okay. So on this EKG, everything else, axis is fine. There really isn't any evidence of LVH. The only thing that we would really code on this EKG is SVT and ST changes with ischemia. So she received adenosine, okay, and then this is her EKG in normal rhythm, a few minutes later, okay. So we clearly have, now we're back in sinus, okay, little tachycardic just due to the stress of the event. While the ST depression is improved, it's still present, okay. The other thing is there's no evidence of pre-excitation, is something that we'll always look at. And if we go back, okay, look at her EKG in SVT, okay, and we look at this pseudo R prime in V1, and we look at this notching, okay, it's not present when she's in sinus rhythm, okay. So, taking this a step further, which is that this was typical avian RT. So this was what an EP would call slow fast, where you're going down the slow pathway and then back up the fast. And this is your notching, is that pseudo R prime in V1 is actually your retrograde P from the retrograde fast pathway. By the time you've come up the fast pathway, the slow pathway is recovered, and then you're back down the slow. Okay, so that slow pathway has a long, PR interval, and then we're back up the fast. Okay, so this, even to be more specific, was typical or slow fast avian RT. Okay, so this was a 20-year-old young man who presented with near syncope. Okay, and fortunately, he was placed in an ambulance in this rhythm. Unfortunately, the baseline isn't the best, but that's kind of typical for EKGs. He was in some slight distress. Okay, as we look at his EKG, as we look at it, most of it is a wide complex tachycardia. Okay, as we look from left to right on a rhythm strip, we're very wide here, and then here for 3 beats we go narrow. Okay, and then we basically resume our wide complex tachycardia. Now the other thing is this is fairly irregular, and probably irregularly irregular. Okay. The other thing to note is that our morphology changes with the rate, okay? Another thing to note is that if we really look at how fast the R to R is on some of these complexes, I mean, we're essentially at 200 milliseconds, or it's getting up to 300 beats a minute. Okay, so the shortest R to R, at times is close to 300 beats a minute. Okay, so hopefully we're looking at pre-excited AFib. Okay, so we have, basically, once again, only two things to code. We have atrial fibrillation, and then we have WPW. Okay, so what happened is we're basically in pre-excited AFib. For these 3 beats, the accessory pathway blocked. He then conducted down the AV node. Okay, so after 3 beats with the accessory pathway blocked, okay, it then resumed conduction, and then he continued to conduct down the accessory pathway for the rest of the EKG. Okay, because if you remember, pre-excitation, okay, is really a matter of fusion between the AV node and the accessory pathway. Okay, so you're getting conduction down both pathways. What happens, and the reason why some of these, are basically what we would call maximally pre-excited, is that, to get up to an R to R that's 200 milliseconds, you really have no contribution of the AV node, and that is all conduction down the accessory pathway. Okay. So, very important EKG to kind of basically, at some point in your career, you're going to see it, and, basically you just want to recognize it very, very quickly, very rapidly, and hopefully, avoid the tendency to think, oh, it's just AFib with right bundle branch aberrancy and give them an AV nodal agent, because that would then lead to all conduction down the accessory pathway, and then that is how patients can then fibrillate. Okay, so but on this EKG, the only thing that we're going to code is WPW and AFib. Okay, all right. So our next EKG is a 57-year-old man who was admitted with heart failure. So one thing I will tell you is that I can't explain why the pacing spikes are green, but those are actually pacing spikes. Okay, so you do have pacing spikes that are occurring, basically at the onset of some QRSs and then in the middle of other QRSs. Okay, once again, if you look at your rhythm strip, we basically have at least 3 different QRS morphologies. Okay, so we have these beats that are really consistent. We have one beat that looks like it's fully captured. Okay, not sure, but we do have one beat that's captured, and then we have one beat that looks fused. Okay, so even though this isn't terribly fast, and it was right at about 100. And it was initially missed because he was hemodynamically stable and just kind of walked in, and they assumed that he had bifascicular block. By evidence, of a capture beat, and clearly by evidence of a fusion beat, he was in VT. Okay, it was really, it's very hard to pick out any clear P waves, but we do have evidence of a capture beat and evidence of a fusion beat. So it has to be VT. Okay, now if they didn't give you that, we would have to then go off of Brugada criteria, but based on that, we're done. We have VT. Okay, the reason why this person had, these basically pacing spikes that were occurring in the middle of the QRS is because he had a biventricular ICD. Well, one feature of a biventricular ICD that some people use, some people will turn off, is what's called a trigger mode, in that if a patient has a PVC, by having a right ventricular lead and by having an LV lead, the two leads in the device can figure out, by whichever lead sees the PVC earlier, where the PVC is coming from. What it will then try to do is it'll then try to pseudo biv pace by pacing into the PVC from the other lead. Okay. Is it effective CRT pacing? No. A lot of us turn it off because it may give you, basically a false sense of better than expected CRT pacing percentage, when you really should be working towards suppressing the PVC so that you have full CRT capture. Okay. Now, clinically, what I hope you would do is, if you're seeing this patient, would be to look at his old EKG. So this was his old EKG, and don't get fooled, don't get thrown by the pacing spikes being so large. He had an older device, and he had an older bipolar LV lead, and those leads didn't have a ton of programming options, and his best threshold or to avoid diaphragm stem, he was programmed in a unipolar fashion with the LV lead. Okay, but if we look at his old EKG, we have dual chamber pacing, so we have an atrial spike. Okay, so we have an atrial spike, and we do see a P wave, so we have atrial capture. We then have a pacing spike. Okay, and then sometimes if you zoom on these, especially you can actually see if there's an offset between the LV and the RV, you'll actually see two particular spikes, which is why we see kind of a green hash, which is probably his RV, and then we have his LV unipolar, which is a very large spike. The other thing is on the coding sheet, they do want you to recognize a biventricular CRT paced QRS. Okay, so once again, you're probably going to be more positive in V1 and then more negative in 1 in AVL. Okay, with more of a CRT paced. Okay, so if we go back to his presenting EKG, clearly, a mostly captured beat here. Okay, but we clearly have a fusion, which is just basically a hybrid beat between his native VT beat and a capture beat, which is why it almost looks like a combination summation of the two. But clearly we're just basically looking at VT, not terribly fast. Okay, barely meets criteria for tachycardia, but clearly in VT. Okay. All right, so this is our next EKG is a 37-year-old gentleman with a history of palpitations. All right, so I'm hoping that the delta waves kind of jumped at you. All right, so sinus rhythm, so we have an upright P wave. Okay, so make sure if you're going to code sinus rhythm that you've got a normal P wave axis. You have an upright P wave in the inferior leads 2, 3, and AVF. Okay, and what you'll notice here is he has the delta wave is negative in 3, but for the most part, it's positive in the remaining leads. Okay, so clearly evidence of pre-excitation. Okay, remember, don't get fooled, because some posterior septal accessory pathways can give you pseudo Q waves or pseudo invert pattern in inferior leads. You're not going to code any type of Q wave or MI pattern. This is strictly WPW. So the only two things that we would code on this EKG would be sinus rhythm and WPW. Okay, and And as a reminder on the coding sheet, WPW is actually under AV conduction. It's not under clinical disorder. Okay, so they actually put WPW pattern under AV conduction. Okay, so hopefully that is clear. Sometimes they will give you, the pre-excitation here is very profound. It really shouldn't be missed. Sometimes they will give you a left lateral pathway. Okay, left laterals are the most common, but they also can have the most subtle pre-excitation, because if you think about it, most of these EKGs are in younger people. They're either having palpitations or they're having a pre-employment EKG. A lot of the colleges now, even through D2, are doing pre-participation EKGs. So you'll have young people getting EKGs with them being in sinus rhythm and them having very good normal AV node conduction. With the impulse starting in the right atrium from the sinus node, the bulk of your ventricular depolarization can occur via the AV node before conduction gets across to Bachman's bundle and over to the left side to actually engage the accessory pathway. So, make sure that you really, if the PR is short, really take, basically look for, subtle pre-excitation in the lateral leads. And then the other thing is look for a, a negative QRS in one in AVL, because you could see that or not with a left lateral. Okay, you may not have a ton of pre-excitation just because the bulk of the depolarization has happened through the AV node, so you have less fusion, which gives you a more subtle or far less pronounced delta wave. All right, so this is a 36-year-old man who was getting an EKG for just basically employment. Okay, so he was undergoing a pre-employment exam, and he was getting an EKG done as part of that evaluation. All right, so I think one thing that I hope will jump out is if you look at your high lateral leads, you look at one in AVL, everything is inverted. Okay, your P wave is inverted, the bulk of your QRS, your R wave is inverted, your T wave is inverted, and that's consistent in both lead 1 and AVL. Okay, if you see this, okay, the thing that your next step, okay, what they're testing is this simple electrode displacement, okay, or is there dextrocardia? Okay, so if you see inverted P, basically everything's inverted in one in AVL, your next step should be to look at your R wave progression throughout the precordium. Okay, with a normal precordial transition, we should develop an R wave typically by V4, sometimes it'll be a little bit late by V5, V6, but if anything, we should be gaining R waves. Okay, in this patient, okay, we're actually losing our R wave and losing our voltage, okay, because he has dextrocardia. So as they put the base of the precordial leads in the normal position, as you get farther out, you're getting much farther away from, he's writing on my screen, you're actually getting farther away from the heart, okay? So if you have, basically if you're looking at one in AVL, okay, and everything's inverted, but you have a normal precordial transition, okay, so you have a normal precordial transition, that is going to be just incorrect electrode placement, okay? In this EKG, everything is negative in one in AVL, but you have basically a very abnormal precordial transition. You essentially have no precordial transition, okay, and you actually lose voltage, lose R wave, you move out. Okay, the two things that we would code on this EKG would be sinus and dextrocardia. Okay. All right, so we have a
Bruce, let me just, if you can just hover on your top floating control panel, I think you should see stop annotation. If not, then I think
okay.
I will take over and remove the annotation.
Okay, I don't know who, it wasn't me. All right, so this next EKG is a 64-year-old gentleman who presented with dyspnea. All right, so hopefully a couple things have kind of jumped out to you as you've reviewed this EKG. All right, so our P waves are upright in the inferior lead, so we know we have a sinus mechanism. All right. I'm hoping that the ST elevation in the inferior leads, okay, and the high lateral ST depression is kind of jumping at you. Now, as we look at our rhythm strip, all right, as we're moving through, we have, our PR is on the longer side, at least at the start of the EKG, okay, gets it gradually longer. We drop a beat, and then we reset, okay, and then as we basically, as the EKG progresses, okay, our PR interval gets longer and longer, all right? But since, okay, so we have Winky Bach, okay, because as we drop a beat, the node resets, the PR gets normal, but then it slowly, basically, the PR stretches until you drop a beat. So this could be, an 8 to 7, a 10 to 9, just because even on this EKG, we only dropped one QRS, but after the drop beat, it resets to a normal PR and then slowly lengthens. All right. So this is not uncommonly seen with an inferior MI, just with the higher vagal tone associated with an inferior MI. But the things that we're going to code is sinus rhythm. Okay, we have second degree Mobitz type 1, AV block or Winky Bach. Okay, we have ST, abnormalities, consistent with an acute injury pattern. All right, and then I would localize that to say we're having an acute inferior MI. Okay. On this one, I think that's about it on the EKG. All right, so we'll move on to the next one. So this is a 42-year-old woman who presented with chest pain. All right, so rate is faster. P waves are upright in the inferior leads. Okay, so sinus tachycardia. All right. One thing that I hope jumped out is kind of V1 and V2. This is especially V1. Okay, so we have localized. We have incomplete, right bundle branch block pattern in V1 with ST elevation, okay? And then we see a little bit of that more in V2, okay? But this is kind of a classic EKG with a type 1 Brugada pattern, okay? So we have sinus tachycardia and Brugada pattern. The only other thing that I would code, and I do not overdo this, but in her, her STs are just not normal. So they're really not consistent with ischemia. They're really not consistent with any type of electrolyte abnormality. They're really not consistent with LVH. But they're just kind of non-specific. So don't overcode that, and that's something that a lot of fellows have gotten in trouble with in terms of overcoding just non-specific ST and T wave changes. But I think in this case, I think it is appropriate to code sinus tachycardia Brugada. Remember on the EKG coding test, your responses are weighted. Brugada may, if an EKG is worth 5 points total, which at least is what I've been told, sinus rhythm may be worth a point, and then the Brugada is worth 3 or 4. So your responses are weighted. But in this case, I probably would code just non-specific ST wave changes just because they're really not normal in any lead. The biggest thing was the sinus tachycardia and clearly the Brugada pattern. All right, so this was a 64-year-old gentleman who was found down. So kind of a lot going on with this EKG. So one thing that we have is, hopefully we can all agree, we're in sinus rhythm, upright P waves, okay, and there's a P wave in front of every QRS. So we're in sinus rhythm. If we look at the axis, it's more leftward, and it's probably over minus 45, which would be consistent with the left anterior vesicular block. Now, as we go through this EKG, I think one thing that hopefully will step out is that we have a lot of voltage. Okay, so we clearly have LVH. The other thing is we really don't have, our T waves are inverted, and they're very deeply inverted. Okay. Now with that, we also have a prolonged QT. Okay, we're approaching 580, 600 milliseconds, and taking into account these deeply inverted T waves. Okay, so we're also looking at prolonged QT. Okay, now when you see these deeply inverted T waves, okay, with a prolonged QT, with voltage, okay, and someone who's found down, this is something where we also would code central nervous disorder. Okay, the other thing that we should code would be left atrial enlargement. If we really look at the left atrial component in V1 of the P wave, it meets criteria for left atrial enlargement. So sinus rhythm, left anterior vesicular block, LVH, prolonged QT, left atrial enlargement, and then to bring this all together into this clinical scenario, especially with these deeply inverted T waves with the prolonged QT, it really goes with some type of CNS event that is leading to these EKG changes. Okay. All right, so this was a 44-year-old gentleman who presented with near syncope. I guess the artist is returning. All right, so if we look at this EKG, okay, hopefully we'll all agree it's a wide complex tachycardia. While not typical, it has more of a right bundle morphology. Okay, and the EPs in the group would say that this is more of an inferior axis. Okay, just being positive in the inferior leads. Okay, so we've got a wide complex tachycardia. It doesn't look like a typical right bundle. Okay, so the next thing that I'm going to do is I'm going to look for evidence of AV dissociation. I'm going to look for evidence of either a fusion beat or a capture beat. Okay, so that's, really I'm going to spend some time looking at my rhythm strip. Okay, so this, I'm not sure what this is. It's a little bit different. Okay, so that's something that steps out. Okay, but as the artist has helped, okay, we get into this beat. Okay, and then we also, okay, so we're probably having basically a fusion beat. All right, so everything continues along until we get to this beat. So you have a fusion beat, so we have VT. Okay, there really wasn't clear evidence of of basically V8 association. It's possible, when I looked at this EKG, this could be a P wave, but is this a P wave? But it was really hard to find something that consistently matched out. But really, ultimately, from a diagnosis standpoint, from a coding standpoint, once you saw this beat, you were done. Okay, if they give you a fusion and capture, it's VT. Okay, if they don't give you a fusion and capture, you don't clearly have V8 association. That's when I usually go into the Brugada criteria to help with the diagnosis. Okay, but in this case, it was VT. All right, so 45-year-old gentleman with dyspnea. All right, so looking at this EKG, as we look across it, okay, it's a wide complex tachycardia, okay, kind of favoring more of a left bundle, but not kind of a classic left bundle, so either left bundle or, an IVCD is what I would code in this one. You're not really QS in V1, but it is more favoring more of a left bundle morphology. Okay, it is very regular, okay. It's at such a rapid rate that we really need to look into our T wave to see if there's a P wave in front of every QRS. So we need to really look in a couple of different leads. We do have notching throughout the inferior leads on the downslope of the T wave. Okay, that's fairly consistent. Maybe a little bit more apparent in lead 1. And then if we look in V1, this notching here and also in V2 matches up. So, favoring sinus tachycardia. Okay. Now, hopefully, what is also kind of jumped out to you with this EKG is that you really have profound ST elevation that is discordant to your QRS. Okay. So, the early or the first Scarbosa criteria was looking, the criteria were met if you had 5 millimeters that were discordant. That's subsequently been modified to 1 millimeter discordant. But either way, we're close to probably 7, 5 to 7 in some leads. Okay, So while a bundle branch block or an IVCD can make the diagnosis of an acute MI more challenging, okay, it still doesn't, basically what we're still looking at is, an anterior lateral, acute MI, so ST changes with suggesting injury pattern, anterior laterally in the setting of, sinus tachycardia with, left bundle branch block, or I think IVCD would also be accepted since it's not really a classic left bundle with the small R wave, and then just in V1, okay? But an acute MI in the setting of a bundle branch block was the big thing with this EKG. All right, so this is a 65-year-old man who presented with a wound infection, and they were getting a pre-op EKG. All right, so as we look at this EKG, okay, we spend some time on our rhythm strip, and we definitely can also look at, there is a pacing spike that is in front of every QRS, okay? So every QRS morphology, basically it's not apparent in some of the leads, but we do have a pacing spike in the precordial leads. So these are all the same complex, okay? So they look more left bundle-ish, okay, or RV paced. So not a CRT pace morphology, but more of an RV pace morphology. Now, so all of these are nice and regular, okay? But as we look at our rhythm strip, we do have P waves that are kind of moving through, okay, that are dissociated from the QRSs, okay? And these measure through. They're two here. There's a notching in the T wave here. There's another one in the QRS, and then there's this one, and these march through. So you have clearly more P waves than QRSs. You have P waves that fall that should be conducted, okay, but are not, okay. And then you have an RV paced morphology, but they're basically, the A is dissociated, okay? Now, from a pacing coding standpoint, okay, we know that we have a, an RV only paced morphology, okay? For every pacing spike, we have a QRS, okay? We don't see any timing where we should have a QRS, but we have a spike without a QRS, or we have no QRS, so we have no evidence of, there's no evidence, of non-capture. We have no evidence of, inappropriate sensing in terms of, this QRS isn't seen, and then the pacer tries to come in here because it didn't see this QRS. So, we have normal pacemaker behavior, okay? So it seems it's sensing appropriately, it's capturing appropriately. Every time there's a spike, there is a QRS, okay? So from a pacemaker standpoint, the device is functioning appropriately, okay? So it's functioning appropriately in a VVI mode, okay? So, one option is does this patient have a single chamber pacemaker, okay? Or do they have a dual chamber pacemaker, and for whatever reason it's been programmed VVI, or in this patient's case, he'd been kind of lost to follow-up, and his device had gone to the electrode replacement interval, in this particular model to conserve battery had, basically gone into a backup mode that was, VVI, 60. And so he was in a non-tracking, essentially in a VVI mode. So it turned off atrial function, okay? And then, he basically needed a generator change out once infectious issues kind of had resolved, okay? But from a pacemaker standpoint, at least by evidence of this, you have evidence that the device is functioning normally in a single chamber, mode. Okay. So sometimes there's confusion with AV dissociation versus complete AV block. Complete AV block is present when the atrial rate is faster than the ventricular rhythm. Okay, it's identified by the presence of non-conductive P waves. Okay, when the AV node and ventricle are not refractory. So you have a P wave that you expect would conduct, okay, but, okay, it doesn't because you have complete AV block, okay. AV dissociation is present if the atrial rate is slower than the ventricular rate, okay, because you just may not have enough P waves, okay, to really evaluate for AV block, because your ventricular rate is faster than your atrial rate. Okay, so your dominant pacemaker at that time is the ventricle. Okay, so let's see. So this is kind of a, I don't know if we have time for this one. We'll try to come back to this one. So this was a 64-year-old man with weakness and syncope. Okay, so hopefully, for the sake of time, you'll notice that the left hand of your EKG is more narrow, and then the right hand side is much wider. Okay, so one of the things that's happening is, so we're clearly in sinus rhythm. Okay, so for every P wave there's a QRS. Okay, and as we move through, I hope one thing that will jump out is that your QT is long. Okay, we're really, probably 580 milliseconds, and at the end of your T wave is really when your P wave starts. So as we move along, we have a little bit of a delay here, or maybe some component of sinus arrhythmia. We then have this QRS is similar, so a PAC comes in, okay. After these longer intervals, our QT is going to stretch. And then what happens is the PAC comes in earlier, and then we have a perfect, basically a PVC and R on T, and then we're into torsades. Okay, so one thing with this EKG, so the patient came in with weakness. Okay, I think we've explained why they're having passing out spells or syncope. But on this EKG, you have a prolonged QT. Okay, one of the things that can give you a long QT, and what I refer to as more lumpy, blumpy kind of ST segments and T waves with a prolonged QT, okay, would be hypokalemia. Hypocalcemia should give you a nice isoelectric line and then a fairly normal T wave, even though the QT is prolonged. So you have a gentleman who's coming with weakness, common complaint of someone who presents with hypokalemia is weakness. Okay, so in this EKG, we have sinus rhythm. Okay, we have ST changes that are consistent with or suggesting electrolyte disturbance. Okay, we code prolonged QT. We would code a PAC. We have an R on T from a PVC, so we code the PVC. And then and then this would be coded by coding torsades. Okay, so and with the clinical disorder, we would also code hypokalemia. Okay, so a lot of things that kind of build us up towards, hypokalemia and torsades. The biggest thing is if you're thinking an electrolyte abnormality, you remember it's two parts. You have to code the ST changes that are suggestive with an electrolyte disturbance. But then the final step is to kind of pin this on, in a setting of a long QT, in a patient presented with fatigue, in this type of ST pattern, you would want to also think hypokalemia. Okay. All right, and this will probably be our last EKG, so we can have time to take a few questions. Okay. So, this was a gentleman, 66-year-old man who underwent TAVR. Okay. So, one thing that we have is we have a P wave in front of every QRS. Okay, so we can measure those out. The PR interval is prolonged, so we do have evidence of first degree AV block. Our axis is more leftward. Okay, and this EKG wasn't the best, but prior EKGs he met criteria for left anterior fascicular block. If we look in V1, he has right bundle branch block. Okay, so we're looking at bifascicular block with a first degree AV block. Okay, now as we watch our rhythm strip, okay, everything conducts, and granted it's a long PR, okay, but this beat comes in early. Okay, so this beat comes in early. The T wave is slightly deformed with a PAC. So the PAC is able to conduct, okay, but what happens is then with our return beat, we go to more of a left bundle morphology. Okay, so this PAC stressed the remaining conduction of the right bundle. Okay, and then when the next sinus beat came in, even though it was slightly delayed, okay, the right bundle was still refractory. He then conducts down the left, he basically, conducts in with a left bundle branch block. Okay, and then after that beat, he resumes. Okay, so at least on this EKG, we have evidence of sinus rhythm, left anterior fascicular block, right bundle branch block, first degree AV block, a premature atrial beat, and then we have evidence, intermittent of the left bundle branch block. Okay, so there isn't a clinical diagnosis for alternating bundles, but this is a gentleman who received a pacemaker prior to discharge, just given his high risk for complete AV block, just with the presence of alternating bundles post TAVR. So I think we'll stop there, and then I'll entertain any questions. Is that okay, Dr. Roy?
Yeah, I think it was an excellent presentation, Dr. Rhodes. Couple questions I think I'm getting is one for coding atrial enlargement. I think people are not sure if it amounts to overcoding, or do you have any comments?
The times that I would basically look for it is if you're basically coding, probably if you're someone who has LVH, I would definitely look to see if it meets criteria for left atrial enlargement. I certainly wouldn't overcode it, but I would look for it if it matches kind of up with the kind of other findings on the EKG. Like for example, that patient that we showed who, had, tremendous LVH, and he clearly met criteria for left atrial enlargement, but I would not overcode it. But I would look for it if you've got, basically other coding features that would tend to run with, atrial enlargement. But I certainly wouldn't go crazy coding. And that's not something you want to. That's something you don't want to overcode, and you just don't. A lot of people. The other thing that people tend to overcode is nonspecific ST and T wave abnormalities.
One other comment, and I haven't given the board, so I don't know. Does choosing one option preclude you from choosing another on the actual board? For example, if you choose WPW, does it take away some other coding automatically, or
no? And that's the issue where no, and that goes to overcoding. So if you're going to code left anterior fascicular block, don't code left axis deviation, because that's part of the criteria for left anterior fascicular block. So unfortunately, you can click all you want on the coding sheet, which is where some fellows have had issues with overcoding.
I think on similar lines, do you code prolonged QT with Brugada, or just code Brugada and leave it at that?
I would typically just code Brugada and leave it like that. On that EKG, it's kind of tough because she was so tachycardic. So that's why I would just code sinus tachycardia and right bundle.
And I think we're getting some questions about AV dissociation and complete heart block. If you can just clarify that one more time.
Yeah. So I think, the when complete AV block, you just want to make sure that you have a faster atrial rates, you have more P waves than QRS complexes, and at least you have evidence, not just one, but at least 2 or 3 times where you would have a P wave, okay, that could have conducted through the node, but just doesn't, okay? Most of the time, on the boards, they're going to give you somebody who's in a slow junctional escape, okay? So you've got a junctional escape rhythm, let's say at 40 beats a minute, and then you have a sinus tachycardia of 120, okay? You're going to have, multiple P waves that could have conducted and just don't. It just basically, you've got the atria doing its thing, the ventricular doing its thing, and there's just no interaction between the two. AV dissociation is, we code AV dissociation if the atrial rate is slower than the ventricular rate. Okay, so for example, if you've got a junctional rhythm, junctional tachycardia, and they've got sinus bradycardia at 40, you may not have enough evidence to say AV block, or you shouldn't say AV block, because your atrial rate is slower than the ventricular rate. Your dominant pacemaker is the ventricular rate. Okay, but in terms of on the boards, at least, the EKGs that I've seen for when they're looking for complete AV block, it's very clear because you have a slow junctional escape and you have sinus tachycardia, and you just have multiple P waves that are just moving through, not conducting. They have no effect on your ventricular or junctional rhythm. Does that make sense?
Yeah, absolutely, Dr. Rhodes. I think Dr. Ashwath can take over from here.
Thank you very much, Troy. That's an excellent talk by the EKGs. I'm sure the fellows really enjoyed it and found it very beneficial. I think we still have a few comments and questions coming through, and we might share them later to you if you want to respond, and we can update that on the website.
Okay. Yeah.
Thank you all for joining this talk. I hope you all found it beneficial. We will continue with, I'm trying to share the information for next week. I don't know if it's showing up.
We can see Dr. Ashwath.
You can see perfect. Yeah. I just wanted to share the information for next week. As you can see, this is going to be a little longer. We should plan to wrap up by 12:15 to 12:30. There's quite a bit of intricacies about cardiomyopathy, so we are trying to see how best we can cover all the topics in 2 weeks. So again, we will plan to wrap up by 12:15 to 12:30. I know this information is not on the website right now, but we are in the process of updating that. This will be available. This is the lecture schedule for next week. Also, the videos from last week have been updated to the website, and we will upload the video from today again to the website, probably by the end of this weekend or early next week. Again, please feel free to share this information with other fellows. For some reason, I don't think all the programs are getting this information. So if you have friends or your social media, whatever it works for you, please feel free to share the information. We will be updating it on a weekly basis. So on our Twitter website for our chapter, for me and for Shubhadeep, we'll all be updating. So if you have fellows or trainees either within the country or outside, please feel free to share with them. And thank you all for joining us on this wonderful Saturday. Stay safe and have a wonderful weekend. Thank you. Trying to find my buttons.